Hi friends, so now we're going to be starting off with pediatrics. This is one of the subjects which is very scoring and very high yield, and the questions also most of the times are simple. So it's one of the larger subjects where you get at least 10 to 15 questions in every exam, and most of these are answerable. So I love this subject, and it's an extension of the integrated system, so a lot of overlap we've already covered. So that's why the most important topics from pediatrics per se will be neonatology and growth and development, from where you get bulk of the specific questions. Apart from that, few specific conditions we'll discuss here, like cystic fibrosis, diarrhea approach, congenital heart diseases, GI emergencies in children. So those will be some clusters that we'll cover in the systemic aspect. So let's start off. The first thing that we will discuss is neonatal, which is the largest chunk, the biggest chapter that we have to do. Out of this, neonatal resuscitation we have already covered in anesthesia, right, along with other CPRs. So let's start off. Few definitions in the very beginning. So what do we call as low birth weight? So all of you know, any child whose birth weight is less than 2.5 kgs is low birth weight. Very low birth weight is any child whose birth weight is less than 1.5 kg. Whereas extremely low is less than 1, right? So these are some specific terms. Now, these are absolute weights, but I cannot say with respect to that particular gestation whether that is good or not, right? So that's why these are percentiles, that for that gestational age is the weight adequate or not. So appropriate for gestational age is any baby whose weight falls in 10th to 90th percentile. Small for gestational age matlab less than 10th percentile, and large for gestational age is more than 90th percentile weight. All right, so large for gestational age, few causes can be tested here. Most important one is Beckwith-Wiedemann syndrome, which is one of the causes of large for gestational ages. Then you can have infant of diabetic mother, very important, macrosomia happens because of higher insulin in the fetus. And then you can also have this in a syndrome called as Sotos syndrome, right, which is genetic disorder where you have larger babies, right? So this is what we need to know. Next, let's talk about physiological weight loss. So every child after birth is going to undergo a period where their weight loses first, right? So this is very important for you to know and to counsel the mother that they should not panic that feeding adequate nahi hai or the baby is sick, right? Because they will lose weight. So two numbers to remember, 10 and 15. So in term babies, they will lose up to 10% of their birth weight and they regain it by day 10. So day 10 se baseline will begin and then they start to put on weight. Similarly, for preterm, that weight is higher. They lose up to 15% of their birth weight and they regain it by day 15. So you can remember 10 and 15 here. Talking about IUGR. Now this is more of an OBS topic rather than a Peds topic, right? So intrauterine growth restriction, we had already studied in gynae, where we were talking about how the estimated fetal weight, if it is less than 10th percentile and associated with Doppler abnormalities, you remember umbilical artery Doppler here would be abnormal, right? So that is what is intrauterine growth restriction. So now let's understand the difference, right? So it could be symmetrical or it could be asymmetrical. So in symmetrical, usually the causes are very early on, right? So early insults such as any congenital anomaly or you have an intrauterine infection. Now this is what is going to affect the fetus as a whole, and this is where the head circumference and the abdominal circumference both suffer. Whereas asymmetrical IUGR is where at a later period of gestation, now you are having uteroplacental insufficiency as the most common cause. That's why we are looking at umbilical artery not supplying the blood, right? So this is where you have uteroplacental insufficiency. So what happens because of that is something called as brain sparing effect. So brain sparing effect is what we were seeing, remember, in OBG. So this is what is paired here. The head circumference is paired, whereas the abdominal circumference, which is the best marker of fetal growth, decreases. What that does is ponderal index now. So ponderal index is what is gram per centimeter cube, right? The weight upon the length, right? Length cube. So this is where asymmetrical, because the entire fetus only is affected. The length and the weight both are, affected symmetrically. The ponderal index actually remains normal. Yeah, because overall baby is smaller. But here, because there is asymmetry, it is decreased, right? So that's what is the catch here. That's what the question can be asked. Prognosis obviously is poor for symmetrical because the insult was early. Whereas here, postnatally, most of these babies will catch up on their weight, right? So that's asymmetrical IUGR. So this is about IUGR. Talking about the most common causes of mortality, here they directly ask you one-liners or they can ask you to arrange, okay? So in a neonate, the most common cause is prematurity related deaths. So this could be because of respiratory distress, intraventricular hemorrhage, apnea of prematurity, right? So all of these complications. Necrotizing enterocolitis. So all the complications related to prematurity, mainly 3 disorders: respiratory distress, intraventricular hemorrhage, or necrotizing enterocolitis, right? So they contribute majority to the mortality. Then asphyxia. So this is usually related to birth, right? Obstructed labor, asphyxial deaths, sepsis or infections, and congenital anomalies. So you can remember PAS C as a mnemonic if they ask you to arrange an order. When we talk about under 5 mortality, you can see how still prematurity in neonatal infection and asphyxia. 3 of the topmost causes are neonatal. So that tells you neonatal deaths must be forming the largest chunk of the under 5 mortality. And then 2 specific causes: pneumonia, diarrhea, right? Infectious diseases. So this is about the mortality. Let's now talk about expanded new Ballard score. So this is a score to assess the maturity of the baby, right? So the gestational age of the fetus was known, right? And now you have the baby in your hands and now you are trying to see what is the real age, because there might be a discrepancy, all right? So this is a score which is used to assess the neuromuscular and the physical maturity features of the baby and assign a gestational age in terms of weeks, and this is what can assign a gestational age from 20 weeks to 44 weeks, right? So it's a wide range that it can give. So here they can ask you, the parameters which are included. So let's see what is included. So neuromuscular maturity, 6 points. As a general rule, you remember flex. More term the baby is or more mature the baby is, more flexed posture will be there and lesser flexibility will be there. Okay, so let's understand. First is posture. You can see as the score increases, the posture becomes more and more flex. Square window. This is where we are assessing the angle of the wrist. You can see more and more flexion, right, as the maturity score increases. Arm recoil, again you can see more flexed posture. So pehle 3 mein flexion is increasing, right? Then look at flexibility. You can see the preterm fetuses are so flexible. You can see their popliteal angle. When you flex the limbs, you are comparing the angle, right? So that's the popliteal angle. Scarf sign is how, how much apart from the midline can your elbow go. So in preterm, you can actually bring it over to the other side, right? So that's scarf sign. And heel to ear, how you can touch. So here you can see the heel is touching the ear itself. So here the common theme is the flexibility as the fetus grows decreases. So flexion increases, flexibility decreases. So these are the 6 parameters. In physical maturity, grossly you should know that the skin becomes thicker as the baby grows. Then you know how we also become thick skinned as we grow older, we don't care. So this is skin. Then lanugo. Now here you have to be careful. Lanugo is the baby hair, right? So this is abundant in a term baby. Preterm may be sparse and postterm maybe these areas keep on shedding. So you have bald areas. Okay. Then everything else, the maturity keeps increasing. So plantar surface, the creases keep occupying the entire sole. Breast bud enlarges. Eye ear cartilage thickens. Genitals, male, female, become more and more, mature. So this is how we are essentially looking at. So you need not know the exact score here. Never been asked, but grossly you should know what we are trying to see here to estimate the maturity in a fetus. Now let's have a look at a few lesions that they might give you in a newborn, and all you have to do is reassure. These are benign lesions, all right? So let's see what they are. So you see this reddish rash, you might feel it's an infection, it's cellulitis, it's not. But they did not name it well. This is what is called as erythema toxicum or erythema neonatorum. So this is what is not toxic at all. This is a benign red rash that can be seen. All you have to do is reassure. E for E, if you do aspirate, you will see eosinophils which are high, but you don't need to aspirate, okay? Then what looks like pustule, so this is what is called as neonatal pustulosis. Again, N for N, you will see increased neutrophils if you do an aspirate, but don't aspirate. Okay, so these are just to be reassured, they'll resolve in a few days. These are what are called as melia. So melia are nothing but epidermal inclusions, right? So they are collections which are seen within the pilosebaceous unit. So keratin accumulates. So that's melia. This is what is a little weird, right? Where you're seeing that there is a vasospastic change and a color change in half of the body. And this is what is like a character, right? Suicide Squad character, which is Harlequin. So this is what is called as Harlequin change because of some sort of vasospastic change. Reassure. This net-like pattern is called cutis marmorata. Reassure. Then you can see these pearls right in the palate. These are Epstein pearls, not files. So these are Epstein pearls, which are also, again, keratin accumulates in the hard palate, right? So just reassure. Then this is what are Mongolian spots. As the name suggests, this is more in the eastern part of the world. Asians, it is more common, right? So this is dermal pigmentation. In derm also we had seen this dermal pigmentation, hence it's blue slate gray in the lumbosacral region. It disappears in 1 to 2 years. This is what is a strawberry hemangioma, also called as a stork bite. So all of these names they have given just so you know the parents feel better. They feel, oh, stork ne bite kara hai, must be a good sign, right? So you tell them it's for good luck, etc. So they don't be scared. So this is nothing but an infantile capillary hemangioma. So this is an infantile hemangioma, and you can remember in derma also we have studied this. In is in. It usually involutes by 1 to 2 years. Okay, so this is strawberry hemangioma, stork bite, infantile hemangioma. Then you may have acne, right? Acne in a baby, it's because of maternal androgen transfers. Then this is what is cradle cap or seborrheic dermatitis. Again, common in a newborn, just reassure, right? It's shed off in a few days. And then two changes which may happen because of maternal estrogen transfer. Okay, so this is seen in female fetuses. You may see breast enlargement, which is called as mastitis neonatorum. Sometimes you may also see, lactation happening as in milk, which is called as witch's milk, again, just because of transplacental estrogen spread. And you may see, pseudo menstruation kind of changes, bleeding from the vagina in a female fetus. Again, just reassure, it's all transplacental hormonal passage. Okay, so these are all the things which are benign and you have to reassure. Talking about temperature. Now, neonate ka temperature is a very small normal range. You can see it's 1 degree. So, from 36.5 to 37.5 degrees normal. From 36.5 to 36 is cold stress, where you'll see that the extremities are cold, but rest of the body is still maintained. So, this is that warning 0.5 degrees Celsius. Then, 36 to 32 is moderate and less than 32 is severe hypothermia. So, just remember 3 numbers. 32, 36, 36.5, right? So this is about hypothermia. How we measure the temperature of a newborn is you measure at the axilla. So this is by convention, axillary temperature is measured for 3 minutes at least. You have to keep the thermometer at the axilla. All right. Now, something that is unique in neonates in their temperature control is they cannot shiver, right? So what they rely on is non-shivering thermogenesis. So non-shivering thermogenesis is what is meant by brown fat. If you remember in biochemistry, we learned thermogenins, uncouplers. They allow electron transport to happen, but they don't make ATP, and all of that energy is released as heat. So brown fat is that thermogenin or uncoupler which is allowing the newborn to generate heat and maintain the body temperature. Sometimes that brown fat can be retained, okay? So this is what is retained brown fat in adults, and this is what is called as hibernoma. Okay, so it can act as a pseudo tumor, because look at this is what is a PET scan, and you know PET CT detects metabolic activity. So we are seeing two symmetrical hotspots here, but the site around the neck, right, is where brown fat is commonly there. So this is why we have to be careful not to mistake it for a lymphoma or something. This is what is brown fat. So you should know where brown fat commonly resides. So nape of the neck, interscapular region, near the clavicle, right? So that is where you can also see here, if you look at the section, this is the trachea. So we're somewhere close to the shoulder joint at the thoracic inlet. The lungs have not yet started, right? So just wanted you to know that this can be retained. It's not that important, but you should know brown fat is very metabolically active. So it can show a false positive, right? What is the takeaway is it can show a false positive on a PET scan. Yeah, so that's brown fat. That's how newborns maintain their temperature. Then let's talk about kangaroo mother care. Very, very important. So kangaroo mother care is where we are trying to care for low birth weight babies who need some extra care, but they are stable enough to not need a NICU setup. NICU means newborn ICU, right? So this is what is indicated in all stable low birth weight babies, right? So any baby who is stable, who does not need specialized NICU care, can do KMC, right? So what is kangaroo mother care? Just how kangaroos, you know, carry their newborns. So we learn something. Why are they carrying their newborns? It must be nature, right? So this is where we are, you know, taking inspiration from nature in medicine, right? So there are 4 components. They ask this. One is kangaroo position. So this is where the mother and the baby are in skin to skin contact, and that's the main mechanism to prevent, you know, hypothermia. So what this is going to do is this is going to prevent hypothermia via conduction. So the mode of heating here can be asked is nothing but conduction, right? So you can see that the baby will wear nothing but the nappies, and you cover the head of the baby, because babies lose majority of their heat, right, from the head, because the surface area of head is the largest in babies. So that's why you're covering the baby's head, and obviously baby is wearing nappies, and then skin to skin contact is what is happening. So that is going to prevent hypothermia. Kangaroo nutrition. So the mother and baby are very close. So this also promotes breastfeeding. So exclusive breastfeeding, multiple advantages, right? So this is what will prevent malnutrition, hypoglycemia, so many other complications, necrotizing enterocolitis. So that's the advantage of kangaroo nutrition. Kangaroo support is where mother and the baby are being supported initially in the hospital, later at their home. They need some support and discharge. So we are promoting early discharge from the hospital, and what that will do is decrease the chances of neonatal sepsis, because the most common cause of late onset neonatal sepsis is hospital acquired infections, right? So that's something that gets prevented. All right, so this is what the component of kangaroo mother care is. Here they say that, you know, you should do kangaroo mother care as long as possible. So minimum one sitting should be, you know, for 1 hour at least, because again and again performing this itself increases the chance of neonatal sepsis and handling of the baby, right, which we don't want. So minimum 1 hour sitting, and you know, as long as possible. And how long to continue kangaroo mother care is not something you will decide, that baby will decide. So when the baby no longer is, you know, staying in this position, being fussy, crawling out itself, right, it will not crawl out, but at least will try to. So that is when, you know, baby no longer needs kangaroo mother care. So when to stop, baby itself will decide. Okay, so this is about KMC. If the baby does need specialized care, so in the NICUs you must have seen 2 mechanisms of heating. So what is this? Is an incubator. So C for C, incubator mein mode of heat is convection. Okay, C for C. Whereas this is what is a radiant warmer. So radiant warmer naam mein hai, mechanism is radiation. All right. So a lot of times we think it's too good to be true. It's too simple, can't be correct. But in this case, it is simple and correct. All right. So incubator, convection, radiant warmer, radiation. Right. So this is all about temperature control. Now we talk about neonatal hypoglycemia. So when we talk about hypoglycemia, what is the definition? So little controversial. So if they mention blood glucose, any blood glucose less than 40 mg per dl or any plasma glucose less than 45 mg per dl. So if they don't write anything, how will you know? So then just take 45, right? Better to keep a higher threshold rather than 40. So if they don't mention, keep it 45. One more number, when we go to severe acute malnutrition, there we will take hypoglycemia because that's on neonate, right? There we'll take hypoglycemia as 54. So I want you to remember three numbers, 40, 45, 45 ko ulta kar do, 54, right? So this is what we need to remember. So this is where you will look at the symptoms, whether the baby is symptomatic or asymptomatic. Now, symptoms of hypoglycemia could range from just jitteriness to something as severe as neonatal seizures to neonatal coma, right? So this is where I want to first teach you how to distinguish jitteriness from seizures. This is directly from OPGI and can be tested. So jitteriness won't have any eye changes like deviation or fixed gaze that is seen in seizures, or it won't have any heart rate changes associated with seizure. Second, the rate. The tremors are much faster, 7 to 10 hertz with equal movements. Whereas in a seizure, there'll be a slow and a fast component, okay? And it is much slower overall, 1 to 2 hertz. So that's very important. And jitteriness is stimulus sensitive. Hunger, crying, loud noise, it will be stimulated, and if you hold restraint, se stop ho jayega. But seizures will not stop, and that is something which is one of the most important features, right? So this could be a potential question, never been asked so far. Okay, right. So any of these symptoms, do you agree the moment the baby has symptoms of hypoglycemia, I can't wait, right? So the answer is obvious. I have to give an IV dextrose bolus here. And that is at 2 ml per kg rate, right? So you will give a bolus immediately and that will be followed by a glucose infusion. Okay, so that story is finished. It's very logical. If the baby is asymptomatic, let's say you are routinely monitoring the glucose, the most important indication for that is infant of diabetic mother, right? Where you will definitely monitor. So infant of diabetic mother, preterm babies, any sick babies, right? So where you will routinely monitor the glucose. So let's say the glucose comes out low. So here you have to see first of all how low. Less than 20 mg per dl or more than 20. So here I am thinking of one number, that's 20. So if it's more than 20, what we can do here is oral. Oral as in breastfeed, right? So this is where you're gonna breastfeed the baby and then see. So if after breastfeeding you monitor and you see that the values have gotten above 40, what do? You continue, right? So you continue breastfeeding. But if the value is less than 40 mg per dl or was less than 20 to begin with, in both of these you have to give a glucose infusion. So you're going to give a dextrose infusion, right? So it looks harder than it actually is. So what did we study? Symptomatic hai, no questions asked, pehle bolus do followed by infusion. If the baby is asymptomatic, more than 20 hai, oral breastfeeding. Now see more than 40, continue. So either that is less than 40 or it was less than 20, I give infusion, right? So that's how you can remember what to do with hypoglycemia. Then going on to neonatal sepsis. So overall, the most common cause of neonatal sepsis, this is a geography dependent, answer actually. So nowadays, most of the hospitals in India are reporting a higher incidence of Acinetobacter. So Acinetobacter now is the most common cause, more than Klebsiella or E. coli. Previously, it used to be Klebsiella E. coli, right? So it's something that they would usually not ask you because this is dependent from hospital to hospital. So this is what is overall most common cause. So you can remember gram negative, right? But early onset, which happens within 72 hours, is overall universally group B strep, because this comes from the mother's vagina, and that's why it will present early. Anything else, it will take time to be caught first from the hospital and then present. So that's why early onset everywhere is group B strep. The most effective method of prevention, and here I'm talking mainly about late onset sepsis, is effective hand washing. So the handlers who are handling, the neonates, the doctors, the nursing staff, the technicians, if they are maintaining hand hygiene, most of these infections can be prevented, right? So effective hand washing, and we've learned it in micro, the WHO steps, Suman K, right? The earliest clinical feature is not feeding, right? So inadequate feeding is what can predispose to neonatal sepsis. Initial investigation is a sepsis screen. So first you will take a blood sample and send for a routine sepsis screen, which is nothing but your routine WBC actually. So what parameters are you looking at here? Leukopenia, so TLC less than, you need to remember these values. So TLC less than 5,000, ANC less than 1800, so absolute neutrophil count, immature to total more than 0.2. Can I say this is equivalent to a left shift, right? So something like left shift. ESR more than 15, CRP positive. So TLC, ANC, immature, ESR, CRP, right? So any 2 out of 5 are positive, this is called as a positive sepsis screen. Okay, so the moment we see that the sepsis screen is positive, we have to send for blood culture, right? So the investigation of choice obviously is blood culture, and sensitivity is what we have to send. But the moment you've taken blood culture, now I will start empirical antibiotics, right? So you do remember this is always after blood culture, right? And that is true for like general practice, okay, that you do not start antibiotics before taking sample of blood culture. So I've taken and I've sent blood culture sample. Before the results come, I will start empirical antibiotics, and then we will modulate according to whatever results come, right? So the empirical antibiotic we choose is ampi plus genta. Ampicillin, covers for listeria. Listeria is a major cause of sepsis in extremes of ages, and gentamicin will cover all of these gram negative organisms, plus minus vancomycin. Okay, so vancomycin is plus minus. The risk factors for sepsis would be preterm babies, rupture of membrane more than 18 hours, that predisposes to chorioamnionitis, positive pressure ventilation. Again, it allows organisms to thrive more, because also you are using, mask, other things which can cause organisms to inoculate, right? So positive pressure ventilation, prom and preterm. Fine. So these are some risk factors. To normals, so a baby should pass first urine by first 24 hours of life, whereas meconium should be passed within the first 48 hours of life. If they don't, in urine you suspect some urinary obstruction like posterior urethral valve. In meconium you suspect most commonly Hirschsprung's disease, right? And they say why meconium is green color. This was a PYQ. It's because of the high content of biliverdin. All right. In the first tool, it's greenish because of biliverdin. All right. So these are some more questions. Next topic, super important, neonatal jaundice. Minimum one question, you will get from this topic. So let's start off with pathological jaundice. So neonatal jaundice can be physiologic. So if you know what is pathologic, you would know what is physiologic, right? So let's do the definition of pathological jaundice. Any jaundice that happens in the first 24 hours is always pathological. Few causes that can present with jaundice in the first 24 hours. Very important, ABO incompatibility. This is where in hemat we had learned, right, that mother's blood group, if it is O, that is what predisposes to this condition, where O blood group is the only place where the antibodies can be IgM and IgG. Other antibodies are IgM usually. So this is where these IgG are small in amount. They can cross the placenta, and the hemolysis is not much, but it's just major enough to cause this jaundice to appear in the first 24 hours, right? So it's because of the A or B antibodies which are attacking the fetal RBCs. So that's ABO incompatibility. So you can take the mother's blood group history would be usually O. Apart from that, very important, G6PD or hereditary spherocytosis. There's also hemolysis that's happening and can present in the first 24 hours. Any jaundice that persists for more than 14 days is also abnormal. So first day, yeah, more than 14 days. So causes of prolonged jaundice, very, very commonly asked question. So prolonged jaundice can be because of one, congenital hypothyroidism, could be because of a cephal hematoma, right? Cephal hematoma is what has bled during birth, and now it's slowly resolving, and there is bilirubin which is progressing. And then the two options they'll give you would be breast milk and breastfeeding jaundice. So very, very important, we'll learn this. It's breast milk that presents as prolonged jaundice, whereas breastfeeding jaundice is usually in the first week. नाम में है feeding first. ठीक है, so it is breast milk jaundice. This is a very commonly tested question. We will learn their details, but remember right now, breast milk jaundice is what presents in the as prolonged jaundice, second, third week. Then the rate of increase. So any rate more than 5 mg per dl per day, any bilirubin at any point more than 15, which clinically we will learn if you have staining of palms and soles. That is what happens at more than 15, and that's always abnormal. Or conjugated bilirubinemia is always suggestive of obstruction. So conjugated more than 1 at any point. So this is the definition. So let's revise. First 24 hours, after 14 days, more than 15 or palms and soles, increase more than 5 per day, or direct more than 1. So if it is not fulfilling this, it's physiological, you can just reassure, right? So this is what we learn. Clinically, we can estimate the level of bilirubin, right? And that is what is called as the Kramer's chart. So this is what is a figure showing the Kramer's chart. So face, so this is directly from OP guys, so you can remember these values. 4 to 6, chest is 8 to 10, abdomen 10 to 12, limbs will be 12 to 14 at any point if it stains the palms and soles, right? This is how you will measure. So you'll blanch and then you'll see the feet and the palms. This is more than 15, right? So this is what is your cutaneous estimation, clinical examination. If this is seeming pathological, the next step is TCB, which is a non-invasive estimate. So that's a transcutaneous bilirubinometer. And once this is positive, it is showing that, yeah, TCB also shows that it's more than 15. You will do a total serum bilirubin. You will now have to take the neonate's blood sample and send for TSB, which will give you conjugated, unconjugated, everything, right? So we directly don't want to prick the neonate. So you will do clinical exam, TCB, then only take a sample. All right. So this is how you clinically monitor. Then what are you seeing here? So this is phototherapy, right? So you can see a blue light, in layman terms hum isko blue light bolte hain, and you can see how the baby's eyes are covered and baby's gonads are covered. That also tells you the side effects. So let me tell you that first itself. So phototherapy, one, can lead to bronze baby, skin discoloration, that is called as bronze baby. You can also have gonadal toxicity, you can have retinal toxicity, you can have diarrhea and dehydration because of this. So these are few of the side effects of phototherapy. So let's do the specifics now. How does it act? Many times asked. So structural isomerization is the most important mechanism where we convert bilirubin into its water soluble form, that is lumirubin, okay, which is excreted in the urine. Photoisomerization converts the Z type to the E type, and photooxidation is the third one, which is least important. So they also ask which is least important, okay. So structural isomerization, photoisomerization, and photooxidation. Now you remember two numbers, 30 and 45. So distance is 30 to 45 centimeter. It's an LED lamp that we use. 45 से याद कर लो 450 नैनोमीटर वेवलेंथ है, एंड 30 से याद रख लो irradiance is 30. So just two numbers, if they ask you'll be able to solve. Now, when to do phototherapy, when to do exchange transfusion. So there are these Lilly's charts that we use, to decide that at what level, at what age, if it reaches the cutoff, we will do. But as a general rule, obviously in the exam you won't have that Lilly's chart to refer. So that's why you should just know as a rough guideline at what age, what is the cutoff for phototherapy and exchange transfusion. So 24 to 48 hours phototherapy, 15, then 18, then 20, and this is 20, 25, 25. So roughly, exchange transfusion won't be done until the levels are as high as 20 to 25, and phototherapy is usually less than that. So that's how you can grossly remember these cutoffs. So now let's go to the approach to jaundice, and this is a super important page, that you get multiple questions from. So when we talk about unconjugated hyperbilirubinemia, so this is where, first of all, let's clear out congenital hyperbilirubinemia. So this is where in unconjugated you have Crigler-Najjar type 1 and type 2, and we have Gilbert, right? So Crigler-Najjar and the milder form Gilbert, in both of these we have a defect in the UDP glucuronide transferase enzyme. Remember phase 2 reaction? So that glucuronidation is not happening, and that's why the unconjugated bilirubin is higher. Okay. On the other hand, conjugated congenital hyperbilirubinemia is DJ, Dubin-Johnson and rotor. So DJ and rotor is conjugated. So this is unconjugated versus conjugated. So let's discuss this first. So all four of these, first of all, are autosomal recessive. Okay? So Crigler-Najjar, two types, type 1, type 2, where you don't have this UDP. In type 1, it is completely absent enzyme, whereas in type 2, it is severely deficient. So one test to distinguish these two is going to be phenobarb. Remember one line in pharma, all anti-epileptic drugs are CYP inducers except. So that except was valproate, but that's not important. What is important is phenobarb. Barbiturates are what are CYP inducers. So they'll induce this enzyme. So that's what I'm trying to do. We give a phenobarb loading test. If the patient improves, that means that there is some enzyme to improve. But if the patient does not improve, right, that must mean that there is nothing, to get induced. So there is complete absence. So this is what happens here. This is how you distinguish. So if the child improves, it's type 2 and you continue on phenobarb. But Crigler-Najjar in itself is a very severe disease, right? Because you have a severe deficiency. So all of this unconjugated hyperbilirubinemia is going to deposit in the basal ganglia, and there is high risk of kernicterus in these babies. Gilbert, on the other hand, is almost, a very mild condition where you will have adults presenting with episodic jaundice whenever there's fever, stress, any, episodic, you're going to have this jaundice. So that's a very mild disorder. Going to DJS and rotor, conjugated hyperbilirubinemia, where direct is higher, more than 1 is always pathological, or more than 2 is abnormal, right? So DJ, rotor. How to distinguish in both of these? The problem is in this multi-drug resistance protein. Remember in CVS we had learned verapamil, ATP binding cassette and all. So same thing. This is the channel which is used for efflux of various drugs, and this is the channel through which the hepatocytes do efflux of bilirubin. So because they are not able to, there is cholestasis. The pigment or the bilirubin stays in the liver. Similarly, epinephrine metabolites stay. So this is why there is black liver. Alright, so it's because of epinephrine metabolites, it's not because of the direct bilirubin. So epinephrine metabolites make the liver black in DJ, whereas it's not there in rotor. So that's how you can distinguish them. So you can remember a little racist mnemonic, DJ Bravo is a player who's black. So black, DJ. Okay, so that's what you need to remember. So DJ and rotor. Alright, so that's done. Then we go to two causes of unconjugated hyperbilirubinemia, which is breast milk jaundice breastfeeding jaundice? Super important. You get one question from this. So first of all, breast milk jaundice. As the name suggests, this is because of the milk. So breast milk is said to have certain substances like pregnanediol or free fatty acids which inhibit the same UDP glucuronil transferase enzyme. So this is a transient inhibition. So this is what inhibits it, and that's why you have unconjugated hyperbilirubinemia for a prolonged period in the second or third week. This is very common, so you can remember third week, 3, that almost 3% of the babies who are exclusively breastfed tend to have this, and this data was asked in INICET last year. Then another statement they used was they rarely need phototherapy. And will you stop breastfeeding? No, you will not stop breastfeeding because it's a transient phenomenon. In some time it's going to sort itself out. So you don't want to ever stop breastfeeding here. So if the levels reach that threshold, you may give phototherapy, but it's rarely required. So all of these points were tested on breast milk jaundice. When we talk about breastfeeding jaundice, this is what happens in the first week usually, and as the name suggests, this is usually because of inadequate feeding, right? The baby is not getting adequate feed because of whatsoever reason. We'll see improper attachment, positioning, right? So inadequate feeding leads to higher enterohepatic, circulation, which results in more bilirubin, leading to breastfeeding jaundice. All right, so here obviously the treatment is to correct the feed, whatever is going wrong, or supplement it. So this is about breastfeeding jaundice, right? Then we go into 2 causes of obstructive jaundice, which is nothing but conjugated hyperbilirubinemia. So very, very important. One is extrahepatic biliary atresia. Second is neonatal hepatitis. Okay, so neonatal hepatitis on biopsy will show us giant cells, lymphocytes, whereas EHB on biopsy will show you periductal fibrosis proliferation leading to the ducts getting occluded. So this is what was tested once as a diagnosis question. Then they had asked investigation of choice. Now this is super controversial. So there are 4 investigations which are done, and I'll tell you the order in which the investigation of choice goes. So first is a fasting ultrasound, where you will look at the gallbladder. So first of all, let's talk about ultrasound. So one is fasting ultrasound. Better than that is a HIDA scan, which is a technetium HIDA scan, right? So that's a scintigraphy study. Better than that is a biopsy, right? So liver biopsy will directly show you the finding. And better than that, the gold standard is intra-op cholangiography. Okay, so this is where what is investigation of choice will depend from department to department. Bailey Love writes that fasting ultrasound is the gold standard for EHBA. If you will ask a pediatrician, they will say HIDA. If you will ask a pathologist, they'll say a biopsy. If you'll ask a radiologist, they will always be right and they'll say intracholangiography, right? So this is where the answers will vary. So what is your learning point? Because you can't say who framed the question. You will say whatever they say is correct. Means if they say HIDA is investigation of choice, consider it true and then assess the other options. If they say intra-op is investigation of choice, consider it true and assess the other options. So here you exclude this and read the others, because this could be anything, as I'm trying to say. But what is better is you know what I'm trying to see in each one, right? So try and understand rather than memorize. So why am I doing ultrasound? What will that show me? When we do ultrasound for a baby suspected to have EHBA, we do it in a fasting state, because fasting is the state where the GB is maximally contracted, right? So I want to see that GB, because once you eat, once the baby feeds, cholecystokinin will make the GB contract, right? So that's why we do a fasting ultrasound. So what are we looking for? So this is the first thing where we look at a sign that is called as triangular cord sign. So this is the portal vein, and anterior to the portal vein, can you see this white thingy here? So this is called as triangular cord. Anterior to the portal vein was supposed to be the bile radical, which was supposed to be black like this, okay? It is because it's also filled with fluid, and you know fluid is anechoic. But here, because there is no bile, it's all atretic, I'm seeing this white fibrosis. So first thing, anterior to portal vein, I'll see this triangular cord sign. Second, when I look at the gallbladder, it was supposed to be dilated because it was fasting, but I do not see a dilated GB. I see something like a ghost GB sign. So this is where, look at the gallbladder, it is atretic, small, ye hai GB. Normally, this is how big the GB should have been. Okay, so this is what is the ghost GB sign. It's a triad where the GB is atretic, less than 1.9 centimeter. It has a very irregular contour, right? So you can see the lumen is very irregular, and we see a very thin wall. So it's essentially just saying that the GB is very small. Don't get confused by this white. This is nothing but the bubble gas, right? So you know air is enemy of ultrasound. So this is the bubble gas which is producing shadowing. So this is the gallbladder and this is the liver. So, two things I'm trying to look for on the ultrasound. Remember, triangular cord sign, ghost GB, triad. Then let's talk about HIDA. So, what am I trying to look for in a technician 99M HIDA scan? So, HIDA is just like bilirubin. Okay, so how bilirubin will come from the liver, will go into gallbladder and then go into bowel, right? So, I am supposed to see the bowel loop, right? So, this is what is showing you a normal HIDA scan, where you can see this is the gallbladder, this is bile duct, and you can see the bowel getting opacified. Do you think in EHBL see the bowel? No. So in extrahepatic biliary atresia, because there are no bile radicals which are supposed to take the bile into the bowel, I will see non-visualization of the bowel. So this is where it is very high, it has a very high negative predictive value. Can I say that? Means if I see bowel, I am very sure it can't be EHBA. But if I don't see, I'm not 100% sure it's EHBA, because it could be some liver dysfunction. It could be neonatal hepatitis. That's why liver is not, excreting the bile. So that is the thing with HIDA, that it can't be the gold standard, because a positive HIDA does not give me as much value as a negative HIDA does. It tells me that this can't be EHBF. So that's the concept. But nonetheless, fasting ultrasound, then HIDA. Biopsy will show you these, and intracholangiography, immediately what we do is we puncture the bile radical and we see if the bile is going or not under an X-ray visualization. So that in real time gives you, whether bile duct is there or not. So that's why this is considered to be the gold standard. Alright. So now coming to treatment of choice, so we would want to do a Kasai procedure, right? So in Kasai procedure, what you are doing is a potoenterostomy, right? So whatever is the last patent segment of the bile duct, you're going to anastomose that with the bowel, right? So this is what you are doing here, but it can only be done for the first 60 days of the baby's life, or till cirrhosis has not set in. The moment cirrhosis sets in, and that's usually 60 days timeline, after that all you will have to do is liver transplant. Okay, so if you cannot do Kasai, you will do liver transplant. And if you remember in surgery, this was the most common indication of liver transplant in kids, EHBA, right? So this is what happens. Kasai classification, so this has never been asked but may be asked. So this is type 1, where the distal duct is atretic. Type 2A is proximal to the cystic duct. 2B is complete, and 3 is where you have the complete segment, right? So even intrahepatic plus extrahepatic is affected, and it's type 3 which is most common. If you remember, we have a trick. It's either 1 or it's 3. Yeah, so here it's type 3 which is most common. So this is what we need to know from EHBA. So now talking about neonatal respiratory distress. So this is where you have to look at two things, okay? One will be a clinical buzzword and second will be the X-ray, right? So first thing, preterm baby. The moment you hear preterm baby with respiratory distress at birth, only one thing should come to your mind, and that is RDS, respiratory distress syndrome, also called as hyaline membrane disease, right? So here what's happening, a baby is preterm, right? So the surfactant is not yet formed. Do you remember from recipe, surfactant, उसके नाम में ही है surface tension antagonist, उसका काम है surface tension कम करना, means it is what is going to decrease surface tension, hence allow the alveoli to open up. So if I don't have surfactant, the alveoli have never opened up so far and they are collapsed. If alveoli are collapsed, can you tell me whether the lungs volume will be increased or decreased? It will be decreased. So one, the lung volume decreases means on X-ray I am going to find underinflated lung fields, smaller lung fields. One. Second, because there is no air in the alveoli, now what's going to happen? They are filled, right? So they are collapsed. So I'm going to see white out lungs, completely white. It's just like collapse. And is the bronchus going to have air? Yes, the bronchus will continue to have air because bronchus में problem नहीं है, distal alveoli में problem है, and that is why I'm going to see something called as air bronchogram, right? So this is what we are going to see in hyaline membrane disease: underinflated lung fields, white out lungs, air bronchogram. All right, so this is how you make a diagnosis of RDS. Now let's discuss that further. So you know type 2 pneumocytes make surfactant. The synthesis begins at 20 weeks. It comes in the amniotic fluid at around 28 weeks, and you know lung maturity is 34 weeks, and that's why any baby who's supposed to be born before 34 weeks will give them steroids because steroids increase surfactant synthesis, right? So that's something you remember. Apart from that, do you also remember insulin is what antagonizes the surfactant synthesis, and that's why infant of diabetic mother may even be term, not even preterm, and yet can have respiratory distress syndrome because their surfactant synthesis is decreased. So that's an important buzzword for you. Okay, so now how to remember these three numbers? You remember viability के दो cutoff होते हैं. Universally it's 20 weeks, in India it's 28. So that's how you can remember. 34 to we know. Right. So now looking at the amniotic fluid, how do we check for lung maturity? I can measure what is lecithin sphingomyelin ratio. So lecithin is what is the mature surfactant. If this is more than 2:1, lungs are mature. So this is normal. So lecithin is DPPC, dipalmitol phosphatidylcholine. Okay. Second, I can check this in amniotic fluid. We stain with this Nile blue sulfatase test. So here blue se mix nahi hona. If it is orange cells, they represent mature lung cells. So maturity is on orange cells, okay, not blue. And that's what they've asked, very old names question, that blue cells indicate lung maturity. No, it's a very trapping question, right? Because naam hai Nile blue. So it's orange which indicates lung maturity. Then we do something called as a shake test where you take amniotic fluid and you take 95% ethanol and you shake. If you can see these multiple bubbles, it indicates surfactant presence. Okay, so this is how we detect lung maturity. Now let's talk about the treatment. Very important. So the treatment of any baby who's having hyaline membrane disease is going to be to give oxygen, right? So the mode of oxygen usually we will start off with is CPAP. So continuous positive airway pressure. If the baby is too sick, you give mechanical ventilation, which is you intubate the child and you give mechanical ventilation. If the FiO2 that is required is more than 30%, right? So some sources write 30, some write 40. OPGAI writes 40, so I'm going to use that. So if the FiO2 requirement is more than 40%, this is what calls for surfactant treatment. So now we will have to give surfactant therapy. Or prophylactic surfactant. If a baby is less than 28 weeks POG, then I know, right, that this baby is going to have very, very immature lungs. So this is where directly we can go for surfactant. So either we can give prophylactic surfactant if the baby is less than 28 weeks. If between 28 to 34 weeks, you start with CPAP or mechanical ventilation. If the FiO2 is persistent more than 40% requirement, then we will give surfactant. How we give surfactant? So previously, traditionally, they would put they would put an ET tube and slowly over days and, they would inject surfactant. Now, what they do is one-time surfactant therapy. So this is where you don't really have to intubate for a long time, and that's called as insure, which is intubate, inject the surfactant, and extubate. Okay, so that's insure, which was asked. And we have even, faster methods where there is a nasal cannula through which you can put surfactant. That's called LISA, as the name suggests, less invasive surfactant administration, or MIST, minimally invasive surfactant treatment. Right, so very self-explanatory acronyms. Okay, so this is how we treat and diagnose and manage hyaline membrane disease. Very, very important. Let's say there was a child who was on persistent ventilatory support, and now traditionally what will happen is we will decrease the FiO2 over time and we'll wean off the baby as the baby's lungs mature. But let's say now the baby is not weaning off, baby's lungs are now mature, POG cross ho gaya hai, but still not able to wean off, is one of the signs where you have to suspect bronchopulmonary dysplasia. This is one of the signs of oxygen toxicity, right? Where because of persistent oxygen, now the lungs have become cystic. So this is where you will have cystic lucencies in the lung because of persistent oxygen. So this is your buzzword that you can't wean off, right? And when you do an X-ray, multiple cysts in bilateral lungs. So that diagnosis is bronchopulmonary dysplasia. Another differential diagnosis in the preterm who's having respiratory distress, but this doesn't present at birth like hyaline membrane disease. It presents between 1 to 7 days, and this is apnea of prematurity. Okay, so the definition of apnea is any apnea for 20 seconds or more which is accompanied by either cyanosis or bradycardia. So that is apnea of prematurity. The treatment of choice is caffeine. Okay, so it stimulates, right, the respiratory centers to breathe. So this is what is about prematurity. RDS, 1 to 7 days, apnea of prematurity. The next condition, this is where the baby is a term baby, and usually the buzzword will be babies who are born by cesarean section. Normally, when the lungs squeeze through the vaginal canal, the fluid is absorbed. But in cesarean, that effort baby is not putting to squeeze the lung, right? So that's why there can be some fluid which is retained. And this was asked very recently, transient tachypnea of newborn. So as the name suggests, transient tachypnea hai because of fluid retention. X-ray में क्या मिलेगा? Fluid. Where does fluid accumulate? So one is CP angle, another is fissures. Fissure is also fold of pleura. So CP angle या fissures में fluid accumulation, and the hypothesis is that this absorption, which is to be mediated via ENaC channel mediated absorption of fluid, is impaired here, and it takes a few hours to clear off and it will go away. So that's transient tachypnea. Then if they give you history as post-term, and one of the buzzword here is meconium stained liquor, right? So this is where baby may aspirate that meconium, and this is meconium aspiration syndrome. So with aspiration, what happens? So anytime there's a partial obstruction, so you know what happens, right? Let's say this is partially obstructed bronchi. The air can go inside, but it doesn't come outside. So this is what leads to hyperinflation. So in RDS, we saw underinflated. In MAS, we are seeing hyperinflated lung fields because of that partial obstruction. And you will see these lines, streaky opacities, yes, which represent the meconium that has been aspirated in the bronchi. The bronchi have become prominent. So streaky, linear opacities is what they would write. Okay, so this is the finding of meconium aspiration. Next condition, the buzzword here will be sibling death. So history hoga sibling death ka. This is where we have a defect in macrophages. So they write surfactant protein B. So this is not surfactant. This is macrophages who are not able to degrade the debris. So that is why look at the lungs. The lungs are full of accumulations, debris. So this is what we call as crazy paving appearance, which is nothing but these GGOs, ground glass opacities, that are filling the alveoli because the surfactants are not doing their job. Okay, so this is crazy paving. And so the diagnosis here is PAP, which is pulmonary alveolar proteinosis. Okay, so pulmonary alveolar proteinosis, as the name suggests, this is where you have accumulation of this debris in the alveoli. The treatment is to clean the lungs. The surfactants are not doing it, so we clean it, right? So this is where the treatment is repeated whole lung lavage. So this child will need multiple such cleanings of the lungs. All right, so this is about respiratory distress. Now let's look at a few anomalies which can lead to respiratory distress. So very, very important in the recent times, they've been asking a lot of questions from this page. First thing is where you can never ever go wrong. What is happening here? Can you see on the left side? So this is right, this is left. Instead of the lungs, I am seeing that these are the bowel loops which have entered the thorax. What's your diagnosis? Correct. This is congenital diaphragmatic hernia, right? So CDH. This is where embryologically the diaphragm is not well developed. It is because of pleuroperitoneal membrane, right? That is what forms the dome of the diaphragm. This pleuroperitoneal membrane is not formed, and because of that, the abdominal contents herniate into the thorax. Here there are two types, right? So you have the Morgagni type and the Bogdalek type. So Bogdalek type is what is the far more commoner type. I want you to remember BPL. So Bogdalek type is where there is a posterior defect on the left side. Okay, so there's a posterior defect on the left side through which the bowel is going to herniate, right? On the other hand, Morgagni is exact opposite. BPL ho gaya. So this has to be anterior defect on the right side. Right anterior में क्या है? Liver है. So this is where only the liver will mildly herniate up, and this is what is much rarer and usually presents as an incidental finding in adults. Whereas Bogdalek, pura bowel, stomach is all in the thorax. So this is what presents as neonatal respiratory distress. And one of the buzzwords that they will use here is scaphoid abdomen, isn't it? So this is where abdomen is going to be empty because it's in the lungs, right? So that's the buzzword that you will look out for clinically. Very, very important. What is it that you will not do here is bag and mask, because as soon as we see neonatal distress, right, in resuscitation program, first thing you do is positive pressure ventilation. You will not do that here, because what will happen? Because of that air, the bowel loops will further inflate and further cause mediastinal shift. So now what's happening in CDHC? Left side ka lung got compressed by bowel loops. Not just that, it pushed the heart onto the other side. So now even the right lung is compressed. This is the only lung really remaining here. So this is why the most important prognostic factor here is what is your lung volume. So that is pulmonary hyperplasia. So this is an old AIIMS question. Nowadays, this is not something which will be diagnosed at birth, right? So this is something which we will pick up on an antenatal ultrasound itself. So you already know that there's a baby who's going to have CDH. So let me show you this prospective, question. How will it look on an antenatal ultrasound? So this is a fetus. Can you see you have the heart, 4 chambers, the 2 ventricles here, and what you see is the stomach, right? So this is what is the gas bubble, again filled with fluid, isliye black hai. So what is the gas bubble? Is nothing but fluid. So this is the stomach in the same plane as the thorax. So this is the abdomen, this is the thorax. So you are seeing stomach in the thorax, and that tells you that this is CDH. So this is an antenatal ultrasound. So what we do on an antenatal ultrasound is prognosticate. So one of the prognostic indexes or indices that we use is called as lung to head ratio. So we measure the amount of lung volume upon the head circumference. Okay, so lung circumference upon the head circumference, and we take a ratio. Ideally, they should be equal. Any ratio less than 1 indicates that this baby will have severe pulmonary hypoplasia. And one of the things, again, a FYQ, future your question here is, what is exit procedure? So in such babies, we plan exit procedure, which is called as ex utero intrapartum intubation. So these babies are gonna be hypoxic, they are gonna have respiratory distress. Why do you want to increase the chance of this hypoxic insult? So by the moment you clamp the cord, you're gonna intubate them before the delivery happens, right? So ex utero intrapartum intubation is what you will do here. All right, so this is super important. So let's say the diagnosis was made at birth. You saw scaphoid abdomen, you didn't do bag and mask. What is it that you want to do first? Again, as we discussed, ET tube. So you want to provide oxygen, ET tube dalenge. Next, I will put NG tube. What NG tube will do is, it will decompress the bowel, and that will decrease the compression on the lungs, right? So decompression of the bowel loop. Then you will take a chest x-ray to confirm the diagnosis. So look at this x-ray now. Can you see intubation ho chuka hai? This is the ET tube. Can you see NG tube is going into the thorax? So this tells you that the stomach is in the thorax. Stomach is not here. This is how normally NG tube should go, into the abdomen. But here it's going in the thorax. So NG tube does two things. One, it decompresses the bowel. Second, it confirms your diagnosis. All right. So this is what you have done, and now you will plan a proper surgical correction. So this is the entire management of congenital diaphragmatic hernia. So these are very potential, and these are getting ahead of the curve kind of questions. Okay. So this is CDH. In the recent times, AIMS has asked this mimicker of CDH very commonly. And what is this? So first of all, look at this X-ray. You're wondering, oh, is this CDH? Looks like CDH, but there's one problem. It is on the right side. Yeah, right side to liver up aana chahiye tha. What is bowel doing here? So whenever you face such a scenario where it looks like CDH, but it is on the right side, think of this anomaly that is called as CPAM. What is CPAM? This is cystic pulmonary airway malformation. Some people also call it adenomatoid malformation, but it's fine. So as the name suggests, this is where the airway is, malformed to form these multicystic spaces. All right. So this is nothing but airway, not bowel. You can see the diaphragm is intact. You will see the liver in place. You will see the stomach in place. So this is just a lung malformation where you will have cysts. So two things can help you distinguish. One, this will have very little mass effect. Okay, because this is lung malformed. It is not something where bowels are pushing. Second, if I do put an NG tube here, that NG tube will go right into the stomach, right? So that is something that can help me distinguish. On the left side, do you agree the major dilemma will be if they give me CPAM on the left? But they usually don't do that. So just remember, CPAM is what looks like CDH, but on the right side. Yeah, so the only mistake you will avoid is don't call it Morgagni hernia. Morgagni mein liver aega, right? So this is what is CPAM. Next anomaly is what is called as CLO or CLH. So this is congenital lobar overinflation or hyperinflation, right? So this is where one of the lung lobes is larger, and it happens because of, in utero bronchial atresia. So normally when the bronchus is atretic, air can come inside but not go outside. So one of the lobes enlarges. So that happens most commonly in the left upper lobe. So look at this. This is one of the coronal CT images where can you see how this left side upper lobe is much darker and larger than rest of the lungs. So this is how it presents. So it usually has mass effect on the other lobes. So this is something which we pick up incidentally, CLO and CLH. And then we have something which is called as a sequestration. So all of these are pulmonary anomalies which are congenital. So sequestration. This is where, normal lungs are supplied by pulmonary artery, pulmonary veins. This is where one of the lung lobes is getting supplied by systemic artery. Branch of aorta supplies it. So can you see this? This is the descending aorta and one of the branches is supplying this lung lobe. So this is what is called as sequestration. This is of two types. One is extralobar sequestration and one is intralobar sequestration. As the name suggests, extralobar is ekdam paraya, somebody else's. Means here the venous supply is also systemic. The venous drainage is also in the IVC. Whereas in intralobar, at least that is pulmonary veins. Alright. So sequestration means systemic aortic supply. Venous, if it is pulmonary, it's intralobar. Alright. So this is where you need to understand that how sequestration is present. First of all, most commonly they are in the left lower lobe and they present as recurrent pneumonia. Okay, so recurrent infections will develop in these accessory lobes and that's how they present. Okay, so these are the different anomalies. You should just know their names. So CDH, the most important, mimicker of CDH, that is CPAM. Congenital lobar overinflation and sequestration is what you need to remember here. So now let's have a look at two scores to assess the respiratory distress. The first one here is Silverman-Anderson. Alright, so this is what is the Silverman-Anderson score. This is used particularly in preterm babies, whereas this is Down score and this is used for both term as well as preterm, right? So this is where you do have questions, previous questions where they've given a scenario and asked you to calculate. So you need to know everything about these scores. So let's look at Silverman-Anderson first. So you're looking at upper chest movement and then four things which are very similarly graded. So lower chest retractions, xiphoid retractions, nares dilatation and expiratory grunt. So upper chest movement, synchronized movement, lag on inspiration and paradoxical seesaw. Okay, so this is where first of all higher score means worse. So you need to be careful. 0, 1 and 2 more marks means more severe. Okay, so synchronized, lags and seesaw. Then for everything else, no retractions, nares dilatation or grunt, just visible or heard with step, or easily seen or easily heard, right? So that's how you can remember this. So what were the 5 points? Upper chest movement, lower retraction, xiphoid retraction, nares dilatation and grunt, right? So that's what we have to remember here. What about Down score? So two features are similar in Down score. One is retraction, second is grunting. Same grading, 0, 1 and 2. So none, mild, moderate to severe. Just remember moderate because sometimes they give moderate and we don't know where it is. So that's something you should see. Grunting none, steth without steth. Okay, so these two are done. What is here is a number, respiratory rate. So remember in anesthesia we have done this, that the normal respiratory rate during CPR it's 40 to 60 for a neonate, right? So that is where you can remember less than 60 is normal. So less than 60, 60 to 80, more than 80. Cyanosis, no cyanosis with oxygen and cyanosis with oxygen, right? So basically despite giving oxygen, cyanosis is persistent. Retraction, grunting ho gaya, air entry, good, decreased, barely audible, right? So what are the 5 features? 2 are similar, retraction and grunting. What else? Here I have respiratory rate, normal is less than 60, right? Then what else do we have? Cyanosis and air entry. So these are your 2 scores, pretty easy to remember. So 0, 1 and 2, remember that. On the same lines, now let's do APGAR. Alright, so this is non-negotiable. You cannot go wrong in calculating APGAR and it's frequently asked questions and these are questions which are very, very scoring, right? So in APGAR, what are we assessing? Itself, you can remember as an acronym. So A is appearance. The only thing different from the last 2 scores here is, here a higher score is better. So the grading is 2, 1 and 0. So just need to know yahan pe higher is bad, yahan pe higher is good. So that way you can remember, okay? So appearance, full baby pink, acrocyanosis, pura cyanosis, okay? Then we have pulse rate. So here pulse is a number, more than 100, less than 100, no pulse. Okay. Then G for grimace. This is where you are irritating the baby with a catheter on the nose, right? So how is the baby reacting? It's crying, pulling away, that's good. If it's just making faces like grimacing, right? So that's something which is a 1 score, and no response is 0. Then we have activity. So we are seeing how flexed the baby is. Remember, flexed was good. So this is where active movement is there. Arms and legs are flexed, but no active movement, and this is no movement. And then we have respiratory effort. So there's no respiratory rate here, there's respiratory effort, and that is strong cry, slow cry, no cry, right? So these are the 5 points. So let's revise 2, 1 and 0, okay? So appearance, pink, acrocynosis, pura blue. Then you had P for pulse rate, more than 100, less than 100, no pulse. Grimace, babies pulling the catheter, just making faces, no movement. Then we had activity, good movement, just flexed, extended. And then we had respiratory effort, strong cry, slow cry, no cry, right? So this is how we remember APGAR, right? So you have to remember that APGAR is a prognostic score. We measure it at 1 minute and 5 minutes. It does not guide resuscitation in any way. Remember, when we did neonatal resuscitation in anesthesia, we never looked at APGAR to tell us what to do next. That is what heart rate does. It guides resuscitation. This is what is a prognosticating score, that lower APGAR is a poor prognosis. There's likely asphyxia which has resulted. Okay, so what are the signs of severe asphyxia? This has been asked 2 years back. Any APGAR which is less than 3 at 5 minutes, that's bad. Any pH, fetal scalp pH also we check. So any pH less than 7, acidosis in the baby, it's bad. Okay, don't mix this with 7.2. Remember, in trauma triad of death, we have done MCH, metabolic acidosis, that's 7.2, coagulopathy and hypothermia, that's 35 degrees Celsius. This is 7. Okay, so you remember, dono 3 and 7, right? No decimals. Signs of CNS dysfunction, which could be hypotonia, seizures, or abnormal moros, or any multi-organ dysfunction. So 2 numbers mainly you need to remember for signs of severe asphyxia. So on that note, what does asphyxia do? So asphyxia mostly will resolve during the delivery, right? So that's why it's so important to recognize obstructed labor, to recognize arrest of labor and intervene, because if the oxygen supply to the baby gets cut off, this is the result. This is hypoxic ischemic encephalopathy. Can I say this is just like stroke for a newborn, right? So this is what HIE does, and you know, HIE is something which is going to be persistent damage. Stroke is not reversible, it's a persistent damage. Time is brain, same concept here. So this is where what results is cerebral palsy. So cerebral palsy is a result of HIE, right? So before I go to seizures, let's finish cerebral palsy first. So the most common type is spastic. Can I say it's an upper motor neuron lesion, right? Brain insult. So it's spastic type, that is most common. It is non-reversible, non-progressive. Once the insult has happened, it won't be progressive. Unlike other neurological diseases, you know, like we study in biochemistry, your metachromatic leukodystrophy, Canavans, all of these white matter diseases are progressive developmental disorders. They worsen with time. Cerebral palsy will be there. It's a static thing, right? Whatever insult happened at birth is what it will remain. It will not progress, right? So that's important. So what is the pattern? Very, very important. So how you know your blood vessels develop. So imagine this is the brain. These are the lateral ventricles. Okay, so near the lateral ventricles, you have the germinal matrix. This is the source of all the blood vessels. So this germinal matrix is what is there in a preterm baby, and as the baby grows into a term baby, these blood vessels go towards the periphery, right? So this is the parasagittal zone, which is the watershed zone. Means if there is any hypoxia, now this is the area that would be affected. All right. So in a preterm baby, where do we expect the insult? The blood vessels are still here. So this is the germinal matrix which tends to bleed in a preterm baby. Whereas in a term baby, now that vessel has already developed, they have a parasagittal injury. Okay, so that's the concept here. So in a term infant, we can have a parasagittal injury, and that results in spastic quadriplegia. You can remember big baby, bigger insult, right? All 4 limbs are affected. Whereas in a preterm baby, we'll have periventricular. Does that make sense? The periventricular white matter is affected because the germinal matrix tends to bleed. And here we'll have spastic diplegia, right? So the pattern in preterm, very commonly asked questions, diplegia. So remember, bada baby, bada insult, chota baby, chota insult, right? And status marmoratus, this is where you have a chorioathetoid type of pattern. Right, so status marmoratus tends to affect the basal ganglia. So this is something that we frequently see in kernicterus, right? So remember Krigler-Najar, severe types where the bilirubin deposits and causes basal ganglia involvement. So this is what we need to remember about the patterns. Now what happens in cerebral palsy is your cortex is affected, right? It is the cortex which regulates the primitive reflexes. We will learn in the next slide all of these neonatal primitive reflexes are inhibited by cortex, and that's how they disappear over a period of time, right? So here what happens is all your neonatal reflexes, that negative inhibition. So cortex is what inhibits these primitive reflexes. Because here the cortex is gone, now the primitive reflexes can be persistent. So we will see whatever the reflexes which were present at birth, they will be persistent, they will not disappear, right? So that is the learning point. Apart from that, there are some more findings that we see, like this cortical thumb. It's also persistence of a primitive reflex. So the thumb is like this, so cortical thumb is persistent. Then because of the spasticity, when they start crawling, you know, have you seen a commando crawling like this? So this is the commando crawl because of the increased muscle tone. So we will see something called as a commando crawl. It's because of spasticity. When they start walking, again, their gait will be very, very spastic. So it's like a scissor that's cutting, you know, one step over the other. So that is what is called as a scissoring gait. Fine. So these are all the findings that we see in cerebral palsy, right? So here, now let's talk about how it will present. So do you agree it can present as neonatal seizures, right? So it can present as seizures, and the most common type is subtle seizures. So in a newborn baby, the cortical network is still quite immature, so it cannot form the well-formed, you know, generalized tonic-clonic seizures that we see in older babies. So that's why in newborns we see subtle seizures, and it's because of the immature cortical network. Okay, so that's what explains the subtle seizures, and we have already learned how to distinguish it from jitteriness. The best prognosis is for focal clonic seizures, whereas worst, W becomes M, is myoclonic, right? Because you might mix the two. So you can remember W and M. Okay. Then, most common cause is HIE indeed. So, hypoxic ischemic encephalopathy, hypoxic insult is the most common cause of neonatal seizures. Other causes could be hypoglycemia. Yes, we already talked about that. Electrolyte disturbances like hypo and hypernatremia. Sodium, anything can lead to seizures, right? High or low. Very, very important, hypocalcemia, hypomagnesemia. Just remember, there's no potassium here. You know, K kills, right? It directly cause the heart to stop, not the brain, right? So that's important. The drug of choice for neonatal seizures is phenobarbital, right? So phenobarbital, now two uses we have done. One is Krigler-Najar 1 versus 2, second neonatal seizures. We don't use barbiturates in adults because, you know, it has dependence. In a neonate, that's not an issue. Even if they're dependent, they can't do anything about it, right? So, I mean, that's not the reason, but still, phenobarb is the drug of choice, all right? And you know, barbiturate, barbiturates, they increase the duration of the GABA chloride influx, right? So, that's how they act. Fine. So, one more important point on similar lines is in refractory epilepsy, we can also use pyridoxine, right? Because what does vitamin B6 do? We had learned this in biochemistry as well. It converts glutamate to GABA. So it is increasing the levels of GABA, hence, you know, treating seizures. So this is how we use pyridoxine. A few questions on investigation. So there is a bedside monitor for monitoring epilepsy in children, monitoring seizures, because they can be subtle, right? So to really confirm, we can do this integrated amplitude EEG. So unlike other EEGs where we need multiple, scalp electrodes, etc., this is where it's an integrated EEG. Just one frontal electrode is needed. So that's why it can be done as a bedside assessment to really see whether there are epileptiform discharges or not. Then to investigate HI, very, very important, what we do initially is a transcranial ultrasound. So in adults, we don't do this because the bone cannot allow sound waves to go through. But in newborns, there's an anterior fontanelle which is open, right, which is a very big space. So we put our probe there and it gives us a window to visualize, and it looks something like this. Can you appreciate this? See, this is what is the lateral ventricle, right? And you remember, this is cavum septum pellucidum. In your biparietal diameter in OBG, I was teaching you this, cavum septum pellucidum. So this is where in babies, the septum pellucidum is filled with fluid and eventually it regresses to form just one membrane, right? So anyways, so this is what is the normal brain. We are seeing a coronal section. And can you appreciate this white? How will you describe this? Hyperechoic. So can I say there is a hyperechoic lesion in the right periventricular aspect? So this is what is representing periventricular hemorrhage, right? So you remember in preterm babies, we said IVH, intraventricular hemorrhage, is one of the major, issues. So this is what it is. So these germinal matrix will bleed around the ventricle and it will extend into the ventricle. So that's IVH. All right. So this hemorrhage is what is best visualized on ultrasound. But if I want to see ischemia, what did we learn for stroke? What's the best? Diffusion weighted MRI, remember? So this is what diffusion weighted imaging looks like. In radio we have done, where you can't see the scalp, the bone, all you see is the brain, and whatever is hyper intense is showing diffusion restriction. So you can see bilateral basal ganglia is affected because the metabolic demand of bilateral basal ganglia is the highest, right? So that's what we are seeing here. So the investigation of choice for ischemic insult is obviously diffusion weighted imaging, MRI, all right. But initially we can do this bedside transcranial ultrasound to rule out bleeding, okay. Then going on to the grading. So this is what is called as Sarnath and Sarnath grading that we use for HIE. Okay, so this is Sarnath and Sarnath grading for HIE, where you have stage 1, 2 and 3. It's just how, you guys behave in class. Anytime a live class begins, everybody is very, very alert, right? So you are hyper alert, activity is normal. If I throw you, your moros will be strong, right? Mydriasis, tachycardia. So this is a very good prognosis, and 99% of these babies will turn out to be normal. Stage 2 is where now midway through the class, you become very lethargic, no doubts anymore, right? You're just saying, ma'am, please finish fast. How long will the class be, right? So that's lethargy. Activity kam ho gaya hai. If I throw you, moros will be weak. Then meiosis, eyes have become small. Heart rate has become small. Some people can throw seizure also. So stage 2 is what is seizure. So S kind of looks like a 2. Out of 1, 2 and 3, S looks closest to a 2. So that's how you can remember. And 80% of these babies turn out to be normal. And then we have stage 3, which is end of the class, terminal. People have gone into coma. No activity, no moros. You throw whatever you want to, no response, right? No pupil heart rate is variable, seizures uncommon. And this is where you have the worst prognosis. Either you will die or these babies have long-term hypoxic sequelae. All right, so this is what you need to remember. So essentially, 1, moros is hyperactive. 2 is seizure. 3, everything is absent. Okay, so this is about HI grading. So now we learn about these neonatal reflexes. Okay, so you need to know when they appear, when they disappear. All right, so the first one, this is what is called as palmar grasp, right? You would have seen these newborn babies, when you go and visit any newborn baby, they are not doing much. There's not much to do with them. So what do? You give them their finger and they'll hold it, right? So that's the only thing that you can do with a newborn baby, right? And after a point, even they are bored, right? By 3 months, they are sick of it, that now everybody is coming, giving their finger. I don't want that, right? So this is where it disappears by 3 months. So this is what appears as early as 28 weeks period of gestation, disappears by 3 months. Then you have this rooting reflex. Rooting reflex is basically when you stroke the side of their mouth, they'll think that, some food is coming. So this is where they'll start opening their mouth and looking for food. So that's rooting reflex. So this also appears at 32 weeks, and that's why, you could start breastfeeding as early as 34 weeks, and you could do spoon feeding at 32. So we will learn that. And this is the first one to disappear. So very, very important, 1 month disappear. So the question here is that which is the first reflex to disappear? That is rooting reflex. Then look at this. So this is where you have to distinguish, is it STNR, ASTNR, symmetric tonic neck reflex or asymmetric. So for that, you have to first know that asymmetric tonic neck reflex is what is going to appear before birth. Alright, so symmetric tonic neck reflex comes after birth. How to remember is vowels stick together always. Here, ipsilateral arm will extend, means whichever side you turn the neck, us side ka arm will extend. So now you can argue ki ma'am, I can't even see that arm, it's covered by baby. So look at opposite. The contralateral arm, can you see, is flexed? Yeah, so opposite means ipsilateral must be extended. So this is very, very effective, otherwise you'll mix it up. Asymmetric ipsilateral arm extend means symmetric mein kya hoega? Can I say ipsilateral arm will be flexed here? Yes. So that's how you can differentiate ASTNR, STNR. So what are their timings? So asymmetric tonic neck reflex appears at 35 weeks and disappears by 5 to 6 months. Its disappearance is very important because this only when it integrates, baby is able to do rolling. So this is where asymmetric tonic neck reflex, your ipsilateral arm is extended, contralateral is flexed, the baby is learning how to roll. On the other hand, symmetric tonic neck reflex appears after birth. So it appears at 6 to 9 months postnatal and disappears by around 12 months, okay? And its integration is very important for creeping or crawling of the baby, okay? So that is why it disappears by 1 year. By that point, crawling is definitely established. Alright, so this is the importance of asymmetric and symmetric tonic neck reflexes. Then coming to the most important one, that is Moro's reflex. So Moro's reflex can be elicited as soon as, you hold a baby and you lower the baby. So the baby will feel the baby is falling, right? So don't literally drop the baby, just lower the head. And what will happen? So the body, the arms extend. So what happens? It's a sequence of changes, multiple things happen. So the palms, the hands open. Then you will see that the shoulders, what happens to the shoulders? The shoulders abduct, extend, and there is anterior flexion of the arms, right? So this is how, you are essentially doing a chest press. So abduct, extend, and the arms open and the palms open. So this is what is Moro's reflex. So this starts to appear at 28 weeks but is well formed by term. Alright, so basically so many components take time. So shuru ho jata hai 28 weeks pe, but by the time the complete Moro's develops, it's 37. So that way you can also assess the maturity of the baby, right? And this should disappear by 6 months. Very important, because if Moro's is persistent, what does that mean? It means that that negative regulation of cortex is not there, right? So this is the most commonly asked question. Persistent Moro's matlab cerebral palsy. If it is exaggerated Moro's, remember HI, so this is HI stage 1 where it will be exaggerated, whereas absent in the later stages, right? So stage 2 or 3 would be a better answer. In Downs also HI is absent, very, very important because of cortical immaturity. And in Kernicterus also we can see it is absent because the basal ganglia has been affected. Asymmetric Moro's means a local cause, right? So something like a clavicle fracture. Clavicle fracture is one of the most common fractures, not one of the, it is the most common fracture because of birth injuries. Then you can have Erb's palsy, very important, where your C5, C6 roots are affected in an upper trunk injury. Humerus fracture, right? So any of the local causes is asymmetric Moro's. So these are very, very important one-liners. Then we have two more reflexes which appear after birth. So one हो गया symmetric tonic neck reflex. The next one that you are seeing, baby को उल्टा कर रहे हैं. So this is where you do bungee jumping, you know, you fall like this. So this is what is a parachute reflex. And the important question here is, this is the only reflex which never disappears. So this is what appears around 8 months postnatal and never disappears. So that makes for a great question. So never disappear. And this Superman-like pose is Landau's reflex. This also appears postnatally. So this appears at 3 to 4 months postnatally, and this disappears at around 2 years. So 3 reflexes appear after birth: symmetric tonic neck reflex, you have parachute reflex, and we have Landau's reflex. Out of this, parachute never disappears, alright, while the other two disappear at around 1 year and 2 years. That's how you can remember. So this page, little volatile, too many facts, but quite high yield, okay. So this is about the primitive reflexes. Then we talk about feeding. Alright, so here I've given you the concept also. So if you remember the concept, then this won't take, you know, too much time to remember. So any baby who's less than 28 weeks, too young, unka bowel is also not mature. So that's why we have to give IV fluids, okay. 28 to 32 weeks is where now the gut is mature, but the mouth is not mature enough. So that is why you can do OG or NG feeding, orogastric, nasogastric feeding. So this is a tube which is called as gavage feeding, right? So gavage is nothing but orogastric or nasogastric feeding. So that's 28 to 32. 32 to 34, now the mouth is working but just not mature enough to breastfeed. So that's why you can feed with spoon, or what this we use in India, this is called paladi, right? So paladi feeding or spoon feeding, you can do. There are these feeding cups also nowadays, so that can be used. And if the baby is more than 34, breastfeeding, very, very important, okay. Going to the fluid requirement, so there's one FMG PYQ on this, right? So again, facts. So smaller babies will need more fluid because unko catch up karna hai, right? So remember that. So less than 1500 gram, 80 ml per kg, and then it subsequently keeps increasing on a daily basis. More than 1500 gram, on the first day you give 60 ml per kg, and it keeps on increasing. And after a week, almost everybody is at 150 ml per kg requirement. All right. So this is what is the fluid requirement. So factual question can be asked from here. Then we go to necrotizing enterocolitis. Very, very important. So this is what is a result of one, preterm, right? So prematurity complication because the gut is not mature enough to handle food, right? Second, formula food. So breastfeed is, you know, nature is always superior than whatever else we can try to do to mimic nature. So breastfeeding is meant for the baby's gut. So any external feed that you give, like formula feeds, becomes a risk factor for necrotizing enterocolitis. And PDA, patent ductus arteriosus. So this is where again the oxygenation of the blood is impaired in PDA, and that is what can also lead to necrotizing enterocolitis because again the bowel now undergoes ischemia. All right, so these are 3 risk factors, very, very important. So staging, what is this staging? You all know this is the modified Bell's staging, and they can ask you to identify the stage, right? So I'll teach you how to do that. 1A is BAT. What is BAT? Bradycardia, apnea, and temperature instability. So remember, 1A is BAT. 1B, B for B, bloody stools. Okay, so BAT, bloody stools. 2A to B, radiology pe aa jao. So 2A is where you have absent bowel sounds and pneumatosis intestinalis. So what is that? So look at this X-ray. But before you look at the X-ray, what happens? Imagine this is the bowel, right? So this is the bowel wall and this is the lumen where I have air. So what happens in necrotizing enterocolitis is now there is necrosis of this wall, right? Mucosa, submucosa, muscularis propria. So this is where necrosis happens and air comes inside. Okay, so this is where you have, you know, necrosis, thinning of this wall leading to air translocating in the wall. So can I say these are trapped air bubbles in the bowel wall, and that is what is called as a string of Pearl's appearance, where the air is trapped in the bowel wall. What happens? There are blood vessels supplying the wall, right? So that's your vasa recta. So now these mesenteric vessels are gonna carry that air, and that air will go into mesenteric veins followed by portal vein. So eventually we will also see portal venous gas. Can you see this? So pehle tha air in the bowel. Now look at this X-ray. Can you appreciate here also so nicely? We are seeing air which is trapped in the bowel wall, and then can you see in the liver these branching lucencies which are nothing but portal venous gas. So you remember 2A pneumatosis, 2B portovenous gas. 3A, 3 letter of DIC, baby is gone into DIC, and 3B perforation. So this is the end stage where the bowel just perforates because of this constant thinning and necrosis. So this is where perforation in a newborn, we have the football sign. We will not see air under the diaphragm and all because the baby is not in an erect position, right? Baby is not standing. So this is where in a supine state, we are going to see how the air encircles the entire abdomen, and that is called as football sign. Okay, so this is what is a sign that now air, can you see, is around the entire abdomen. So this is what is pneumoperitoneum. Management: until pneumo happens, we don't want to operate. Once perforation happens, you will have to do resection anastomosis. Before that, you try and offload, है ना, bowel को rest do. Nil per oral, give fluids, give antibiotics. So that's what you are doing till perforation happens. So that's the Bell stage. Come on, let's revise what was 1A, that was BAT. Bradycardia, apnea, temperature. 1B, bloody stools. 2A, pneumatosis. 2B, portovenous gas. 3A, DIC. 3B, pneumoperitoneum, right? So they can ask you a question from this. Now we talk about torch infections. Super important because overlap of Peds, OBG, micro, PSM, right? So this is very, very important, right? So we'll cover everything that you need to know, and many factual questions, get asked from this. So I've tried and compiled each and every, question or fact that has been tested from here. So the first infection, this is where you have hydrocephalus, chorioretinitis, and parenchymal calcification. So this is the triad of congenital toxoplasmosis, right? So this is toxoplasma. This is where you'll have hydrocephalus, that's dilated ventricles. Chorioretinitis, remember in opthal we have studied headlight in a fog appearance. If we don't treat it, it will result in a macular scar, right? So we have seen these pictures. Parenchymal calcification. This also we have seen in radiology where the calcification is in the cortex. Maximum transmission happens in the third trimester. This was asked last year. Okay, so final trimester you have maximum transmission. All right, so this is toxoplasma. Obviously, the rule of all torch infections is the earlier the infection transmission, the more severe it will be, right? So this is more about when is it crossing maximally. So that's third trimester. Okay, so that's toxo. You will also have history of cat handling, right? So they'll give you that there is a pregnant female who has a cat and she handles her feces, and that's where commonly this transmission happens. Then very important, CMV, the most common torch infection, cytomegalovirus. So this is what happens, maximum transmission happens if you acquire CMV during pregnancy. So there are two things, right? CMV, like any other herpes virus, is what is dormant in the body. So either you can acquire it for the first time in pregnancy or it can reactivate in pregnancy. So the maximum transmission happens when it's acquired in pregnancy, and that's where you have more severe manifestations. So that's been asked. Then what manifestations? So microcephaly is defined as any head circumference which is less than 2 standard deviation or below the third percentile. Periventricular, so parenchyma is toxo, V for V. Periventricular is CMV. Most common long-term sequelae, many times asked, is SNHL, sensory neural hearing loss. Most of these infections are asymptomatic in baby, means 90% of CMV will be asymptomatic. All right. And how do we diagnose it? Is you can do a PCR to detect CMV, right? And the samples frequently taken are urine and saliva. We don't prefer blood because the blood viremia is not that severe enough to be detected. So urine and saliva are usually common samples for torch infections. Okay. any, torch infection, the general diagnostic principle is, tell me, can I check IgG of that organism? No, because IgG to transplacental transmission hai, right? So that itself indicates maternal transmission of immunity rather than infection. So never check IgG. IgM we can check, because that means that the baby has formed IgM, means baby ko infection hua hai, or I can check PCR, directly check the organism. So these are the two diagnostic methods that we check for detecting torch infection. So remember these general principles. More severe if transmitted in first trimester, detect IgM and PCR, not IgG, right? So these are common things that we need to remember here. Then third one where we can get calcification, this is at gray matter white matter junction. This is Zika. This was asked as a life cycle image based question where they showed a mosquito and there was one pregnant female, like better drawn pregnant female, and whenever you see a cycle with mosquito and pregnant female, it's Zika. All right, so which mosquito? Aedes, right? So all of these were Aedes. So microcephaly hoga, there can be contractures, there's calcification, and this is a expected question. The mutations or genetic predisposition is with these mutations, that's TIM1 and TAM-XL. Okay, so that's Zika virus. Contracture से ही याद रखो, cicatricial skin rash, limb hypoplasia is what is seen in varicella. So this is congenital varicella. So when will we have congenital varicella syndrome? That is when a mother is exposed to chickenpox during pregnancy. So let's say there's a pregnant female, never got chickenpox vaccine, never got chickenpox in her life, means she is non-immune for chickenpox. Let's say she got exposed to chickenpox during pregnancy. So now she will transmit it to the baby. That's called congenital varicella, and uska risk is maximally during 13 to 20 weeks. So do you agree, in this scenario, what do I have to do? So in this scenario, I need to give varicella zoster immunoglobulin to a pregnant female who is non-immune. Very, very important. So if a non-immune pregnant female gets exposed to chickenpox, she becomes high risk and I have to give varicella zoster immunoglobulin, and that will prevent this. Okay. Then what is neonatal varicella? So this is where now the baby is no longer a fetus, baby is born and mother develops chickenpox during the time of delivery. So now who will I give the varicella zoster immunoglobulin? Do you agree? Now the newborn is the high risk here. So this is where you will give varicella zoster immunoglobulin to the infant if a mother develops chickenpox either 5 days before delivery or 2 days after delivery. So remember these numbers. यहाँ पे varicella zoster pregnant को जाएगा, congenital varicella. यहाँ पे mother has gotten chickenpox. No point of giving varicella zoster immunoglobulin now. So now you give to baby. Okay. So here only I just want to, because this is where I've seen students confuse a lot, I just want to give you this template. So this is where you need to remember one template, that let's say there is a patient, all right, forget about pregnancy, newborn, everything. What to do with chickenpox case, right? So anybody who develops chickenpox, you isolate the case first of all, and you can give them acyclovir. All right, so isolate plus minus. So acyclovir is what will increase the recovery. All right, so that's with a case. So now what to do with contacts? So let's say this case developed in a boys hostel. That's a PYQ. So boys hostel mein ek chickenpox ka case aaya. What to do with all the friends who were exposed? So here we are assuming that the contacts are, immunocompetent, normal contacts. What to do with contacts? So if the contacts are immunocompetent right now, so let's divide this into contacts being immunocompetent and immunocompromised. So if they are immunocompromised contacts or high risk contacts like our pregnant female, remember, in that case I have to do varicella zoster immunoglobulin, right? We never mix this with the vaccine. So just varicella zoster immunoglobulin. And can I say this high risk also includes pregnant females? This high risk also includes a newborn baby. So that kind of explains you the last chart. But if the contact is immunocompetent, like the question they asked in the boys hostel, here what do? Nothing. So if they are immune already, they have no fear. But if they are non-immune, we give them varicella vaccine. So you give them varicella vaccine if they are not yet immune. All right. So this is all that you have to do. So contacts, you will observe them for symptoms, and if they develop cases, obviously you treat them like case, but if they don't, you give them the vaccine. Otherwise, just observe, just chill. All right, so this is what is the summary of chickenpox at any point of time, and this is, little important. So you may want to see this part one more time, get your, speak it out once, teach it to yourself, and then move forward. Fine. So this is about chickenpox. Then, if the baby develops skin eye lesions, encephalitis, this is what is because of HSV. Which HSV now? Could be one or two, both, but it's HSV2, which is, your sexually transmitted disease. So, if a mother has active lesions, active ulcers, never ever do vaginal delivery, do cesarean section, and that would have prevented this. So, if you do a vaginal delivery and the baby catches herpes, they'll develop these findings. Very, very important, congenital rubella, right? So, congenital rubella syndrome, what is the triad? The triad is SNHL, cataract, PDA. So, sensory neural hearing loss here also and CMV also. SNHL here also is the most common finding. Cataract. The most common cataract in congenital rubella is nuclear pearly. But you may also see your lamellar type. Remember lamellar or zonular cataract, which is the most common congenital cataract causing visual impairment. So, wo bhi mil sakta hai. But if asked a one-liner, nuclear pearly. But the most common eye finding is not cataract, which is a part of the triad. That is salt and pepper retinopathy. So again, like 3 questions, you need to be careful what they are asking. Triad में cataract hai, but overall most common is salt and pepper retinopathy, and you have patent ductus arteriosus more than pulmonary stenosis. There is expanded rubella. This is a very potential like give party to ma'am question. Okay, so this is where you have diabetes and renal diseases as well. Maximum transmission happens in first trimester, and this is the one overall, this is a PYQ, which has the least risk of perinatal transmission. So this is congenital rubella. So the maximum transmission happens if a mother catches rubella, non-immune, right, who has never got an MMR. So a non-immune mother catching rubella in the first trimester, it's the worst case scenario for the fetus. Okay, and finally, parvovirus B19. So this is what will go and cause pure red cell aplasia in the fetus, leading to fetal anemia. So this is what is not because of immune. So this is the most common infectious cause of non-immune hydrops, right? So this is all that you need to know. So they can give you, micro OBG integrated questions. So very, very important page this one, right? So this is about torch infections. So now let's talk about growth. So this part now super important, all right? So when we talk about the growth related changes, you need to know these parameters. So how does the weight change with age? So let's assume the birth weight is X. They ask you when does it double? So it doubles at 5 months. So you can remember these facts. Again, I've like put a lot of facts here just so that sometimes they can just randomly pick a line and ask. Okay, so these are from OP Guy, and please like remember everything which is written here. So a baby will put on around 30 gram on an average for 3 months, so 33, and after that they gain around 400 grams per month for the first 1 year, right? So remember these 2 points. So 2x ho jata hai at 5 months and it becomes 3x at 1 year. Very important. So after that, keep on adding 4x, 5x, 6x, 7 is the year of symmetry. So 7 pe 7x and 10 year pe 10x. A normal baby has a birth weight of around 3 kg. So you can remember like 10 years mein wo 30 kg ka bachcha ho jayega, right? So this is about weight. Then when we talk about height with age, so here we'll do specific numbers. So usually the birth length is 50 centimeters. At 3 months, it becomes 60. At 1 year, it becomes 75. So this is where the baby will grow the maximum. in your entire life, your maximum growth happens in the first year, because never again you are going to have a 50% increase in your length, right? So that's your maximum growth. 2 years, it becomes 90 centimeter. Here the question is, at what age does baby become half of the adult length? So on an average, if we consider adult length to be 180, baby is half of that at 2 years. 4 years पे जाके अब double हो रहा है. So what was doubling? Weight was doubling at 5 months. The length doubles at 4 years. Okay, so that's important. And from that point onwards, baby will keep gaining around 6 centimeters till 12 years, where the baby usually becomes on an average 150 centimeters. So this is where you're tripling your height. So compare with weight. डबल हो रहा था 5 months पे, यहाँ पे डबल हो रहा है 4 years पे. ट्रिपल हो रहा था 1 year, and now it's taking 12 years to triple your birth length. Yeah, so that's important. What we use to measure the length of the baby for the first 2 years when baby can't stand is this. This is called as infantometer. Used till around 2 years, and after that the baby can stand, right? So that's a stadiometer, stand, okay, where you just like measure the height. Okay, so that's about height. Upper segment to lower segment. So what is upper segment? Anything above the pubic symphysis, right, is upper segment. Anything below the pubic symphysis, lower segment. So at birth, you know, upper segment is bigger, right? The head is biggest. So that's 1.8:1. 3 पे हो जाएगा 3, so 1.3. And 7 is year of symmetry, so that becomes 1:1. And after that point, it is 0.9:1, where the upper segment is actually smaller than the lower segment. So this is what we need to remember here. So then talking about head circumference. So head circumference at birth is 32 to 35 centimeter. Remember that number, all right? So 32 to 35. How it grows? First 3 months is the maximum growth that's ever going to happen. That's 2 centimeter per month. More than that is also abnormal, because that indicates some intracranial pathology leading to hydrocephalus, right? So more than 2 is always abnormal. So the highest for the first 3 months is 2. Iske baad keep doing half and half, right? So next 3 months it becomes 1 centimeter per month. After that, for 6 months, it becomes 0.5 centimeter per month. And then for the next 2 years, it's 0.2. So keep doing half-half. All right. So this is what we need to remember. By 12 years, it reaches 52 centimeter, right? And that's what is the maximum that your head circumference ever will be. So this is about head circumference. The advantage of remembering this is you can also remember chest circumference. How? So head circumference is more than chest circumference. You know, head is the biggest part at birth. So head circumference is higher by 2.5 at birth. So that also tells you that chest circumference at birth is 32 to 35 minus 2.5. At 9 to 12 months, it becomes equal. So we can calculate that what is the head circumference at 1 year, and that's the chest circumference at 1 year. And after that, the chest circumference keeps on increasing. So the best question here is, what is the chest circumference at 1 year, right? So how do we calculate? So let's assume 35 centimeter is at birth. So first 3 months, 2 3s are 6. It will grow by 6 centimeter. Next 3 months, 1 centimeter per month. So 3 ho gaya. And next 6 months, 0.5. So wo 3 ho gaya. So can I say the net increase in the head circumference in an entire year is 6 plus 6? That is 12 centimeter. So that becomes 47. Why I am doing this maths is so that you can remember that 47 centimeter is the head circumference and the chest circumference at 1 year. So if you've already, studied this, it will take you lesser time in the exam to do it, right? So that's the important part. Then what do we measure through this instrument? So this is your mid upper arm circumference. This is a Shakir's tape. So this is something that the grassroots workers can use. And what is the advantage of mid upper arm circumference? The advantage is this is age independent. For weight, for height, everything I'll need a chart that for that age what is normal. But this for 6 months to 5 years, we can see everybody would have the same mid upper arm circumference, right? So this becomes very convenient because it's age independent. So you can see anything more than 12.5 centimeter, it's healthy, no malnutrition. 11.5 to 12.5 is what is malnutrition, and less than 11.5 is red, so that's severe malnutrition, right? So it's color coded so that you can triage as well. So this is Shaki's tape for mid-upper arm circumference. Then let's look at arm span. So arm span, if you stretch out your limbs, from the middle finger to the other middle finger, the length that you will measure is the surrogate marker of height. So that has been asked, and how it relates. So there's just a few centimeter difference. So at birth, the arm span is lesser than length by 2.5 centimeter, becomes equal at 11 years, and after that point, arm span is 1 centimeter bigger, right? So it's the best surrogate marker. Another question, FMG repeat question, how to calculate mid-parental height. So first of all, you take an average of mother and father's height, right? So mother's height plus father's height divided by 2. For boys, you add 6.5 centimeter. For girls, you minus 6.5 centimeter. And that gives you the mid-parental height. So for boys, add. For girls, you subtract. Okay, so this is what we need to remember here. Then we talk about short stature. So here, very, very important, we are looking at the proportion. Proportionate short stature. This is what would happen if the growth hormone was low, right? So all the body parts are smaller proportionately. So that is decreased growth hormone deficiency. For disproportionate short stature, I want to say, is it short trunk? Is it short limb? Remember anyone, right? So let's remember short trunk, because anything that goes wrong with the spine would have a short trunk. So what is that? Spondyloepiphyseal dysplasia. Spondylo naam hai. Mucopolysaccharidosis we had seen, there is beaking of spine, spondylodegeneration hota hai. Pot spine. Alagil syndrome has butterfly vertebrae, which is nothing but hemivertebrae, right? So this is where in Alagil you have triangular facies, okay? Hemivertebrae, so triangular vertebrae, and most importantly, there is congenital hepatic fibrosis, liver fibrosis. Remember, we had also studied this in ARPCKD. So both of these are causes of congenital liver fibrosis. So that's Alagil for you. So anything with the spine is short trunk. Anything where the epiphyses are problematic, the limbs will remain short. Rickets, achondroplasia where metaphyses are degenerative, osteogenesis imperfecta, bone is not forming, hypothyroid, again epiphyses are not well formed. So these are all short limb, but no need to memorize, just memorize short trunk. Don't even memorize, like just understand vertebral issue, short trunk, right? So many questions from this page, like golden page you need to master. Okay, more on growth and development. So let's talk about this. So they have asked this graph. So brain growth is maximum at 2 years. After that point, your brain doesn't grow much in size, right? So can I say our NEET PG rank was decided at 2 years only? Abhi chahe kitna bhi pade. So this is what is your maximum brain growth. Lymphoid growth we can see is happening from 2 to 8 years, right? So middle childhood you will have maximum proliferation of adenoids, tonsils, and then they all regress. Gonadal growth is very easy, obviously will happen after puberty, and somatic growth keeps on continuing. So they can ask you match the following, know any two, brain and gonadal, you will be able to solve. Okay, then we talk about the puberty sequence. All right, so super important. Puberty, the order here you will remember is TPM. Okay, for both males and females. So in females, the first sign of puberty is thelarchy, which is breast development, followed by pubarchy or pubic hair development, followed by menarche. So TPM. Growth spot precedes menarche. So this is where the females will have a growth spot, rapid increase in height before menarche, and this happens relatively earlier in females, corresponding to Tanner stage 3. Whereas in males, again TPM, first is testicular enlargement, then penile enlargement, and then you have male pattern of voice and hair coming as the last change. And again before that we will have the growth spot, the increase in height of males, and that corresponds to stage 4. Means puberty wise girls ki height pehle badhegi, girls will grow taller before boys. Alright, so that is what is TPM. So thelarchy, pubarchy, menarche, testicular, penile, male voice hair. Alright, so this is the order. You know we have a sexual maturity rating to assess the puberty. So you may or may not memorize it. It's been it's never been asked so far, but seems a little important. So this is your Tanner staging, where you assess three things: male genital appearance, you're assessing the pubic hair pattern, and breast appearance in females. Okay, so for male genital pattern, you are looking at testicular volume. So first of all, stage 1, can I say, is prepubertal, right? So this is what any child would show. So prepubertal. And stage 5, can I say, is adult. So they can't ask you 1 and 5 and you don't even want to memorize. So it's a child and a mature adult. So the best questions would be either 2, 3, 4, right? So that's what we want to assess. So testicular volume less than 3 ml. What is this? So this is what is Prader's orchidometer, which is used to assess the testicular volume, right? So this is what looks like Tirumala beads in contraception, but it's not. So this is where you are seeing the testicular volume, okay? Right. Anyways, so this is less than 3 ml. First stage would be change in texture of scrotal skin, penile testicular enlargement, and further enlargement with development of glans penis. Alright, so that is what is male genital pattern. Then they can ask you this, okay, more likely than male genital appearance. So this is where you can get a question: no pubic hair. Remember the buzzword sparse. जैसे ही सुनोगे sparse, think of stage 2. Okay, so sparse growth, darker adult type hair in a smaller area towards the medial surface of thigh, it extends. So here buzzword, remember, sparse hair is stage 2. Then breast appearance, first you have papilla elevation, breast bud, then you have both breast areola enlargement, then projection, and then recession of the areola. Again, here I feel you can just focus on stage 4, where you have projection of the areola and papilla, and then the areola recesses, the papilla projects out. Alright, so this is about the puberty development. Then let's have a look at short stature. Many questions. How do we define short stature? Any height which is less than -2 standard deviation or less than 3rd percentile, right? So this is the definition of short stature. Very important, you compare the bone age with the chronological age. Most commonly, we utilize the left wrist to assess the bone age. So, most common convention is left wrist X-ray that we compare order for bone age. Okay, so if bone age is lesser than chronological age, can I say that is what indicates ki scope hai? There is scope that it can still grow. So that is actually a good sign that bone is still smaller. So that is what is nothing but constitutional delay, that there is scope. Later on bone age will catch up. Okay. But if it is equal, means there is no scope. You will stay short. So one, familial short stature, and can I say any other pathological cause also, the height will remain small, the bone is smaller. So I can say hypothyroidism, let's say growth hormone deficiency. So better to remember this. When there's a discrepancy, it's a constitutional delay. All right. But very important, the height velocity, the rate at that particular age is what is normal. Very important information from a guide table, OP guide table. So height velocity in constitutional and familial is normal. What about puberty? Can I say in constitutional delay, even puberty may have constitutional delay, but in familial short stature, puberty is hit at a normal age. There is no delay there. Okay, so that's something which is also important. So now look at this graph. If yellow was normal, what is blue? So blue is this person. You know how there are some students whose scores in the GTs are always lagging, never really top in any GT. But when it matters, they catch up in the final exam, right? So that's nothing but constitutional delay. End mein catch up kar liya. So can I say this graph here is constitutional delay, right? Then look at this. They always lagged and end में भी lag हुआ. Why? Because their parents were short. Familial short stature. Okay, so that is familial short stature where your height will be lesser because your parents are short. Then look at two curves now. The first one where you were growing, you were ahead of the curve and suddenly you fell sick. Let's say right before the exam you fell sick and then you couldn't catch up. So this is what is some pathological disease which has happened postnatally, after birth. Let's say growth hormone deficiency, hypopituitarism ho gaya. And can I say this curve where you always lagged behind severely, there was some prenatal insult, right? Let's say there was was a torch infection, let's say there was aneuploidy, for example, Turner's, they'll always remain short, right? So that is what is a prenatal insult. Pehle se hi lag tha. So this is such a wonderful graph, where you can ask multiple questions. This is again from OP Guy, where this seems like a potential MCQ material, never been asked. How do you describe failure to thrive? First of all, it's not a disease. It's a descriptive term to describe symptoms, right? So failure to thrive is a term that we use in children who are less than 5 years, where either their weight is below third or sometimes fifth centile is used. Failure to gain weight over time, or their rate is not normal. They are crossing two major centiles. For example, lag okay 50 and 10th se niche aa gaye. You were above 50, cross two centiles, 5th and 10th, and lagged, right? So either you are, decreasing markedly, the rate is changing, or you were always below third or 5th centile, right? So that is what is failure to thrive. So I've exactly, copied this from OP Guy because I feel this may be tested. All right, so that's failure to thrive. Then we have 5 components of nurturing childcare, again from the textbook. So they can ask you all except. So what is a parent's duty really? 5 things. Good health, to provide good health for the children. Adequate nutrition, responsive caregiving, where you are there to listen to the child's problems, solve them for them. Security and safety, and opportunities for early living, right? So that's what a parent's job is, to provide these 5 things. Right? So that's something that we need to remember. So we've done normal growth and development. Now let's talk about when it goes wrong, malnutrition. So for malnutrition, you need to know these 3 terms, super important. Stunting is low height for age. When the height lags behind, that indicates that there is some issue for a long term. So this is what indicates chronic malnutrition. Okay, so chronic malnutrition, stunting. Wasting is what is acute malnutrition. So this is where we have low weight for height. Very, very important. You know how we say if you party too much, you'll say, I got wasted last night. So that's an acute thing, right? So wasting is acute. Weight for height. And underweight, weight for age is both. So it is acute on chronic malnutrition, right? So it represents both. So remember, weight for height is wasting. Now, can I say any of these values when they are lesser than -2 standard deviation? That is what indicates malnutrition. And when they go lesser than -3, we add a word severe to it. So if I have to define severe acute malnutrition, which parameter will I use? Weight for height, wasting, and kitna hona chahiye? Less than -3 standard deviation. So this is a term we use for 6 months to 5 years, where weight for height is below -3 standard deviation, acute है, wasting हो गया, or you remember mid upper arm circumference below 11.5. So this is what is severe, right? So this is what we see, or we are seeing edema. So that's the criteria. Do you have to memorize it? Not at all. So this is what is severe acute malnutrition. Right. Now let's discuss kwashiorkor marasmus. This you would be learning from school. Kwashiorkor is protein deficiency, right? So this is where the deficiency is not of overall calories, it's protein. A child who's eating just carbs, let's say eats cake all day. So that's kwashiorkor. Can I say it's equivalent to nephrotic syndrome, where the protein was less, right? So this is where the serum albumin is less than 3 grams per deciliter, like nephrotic syndrome. Here, there is edema, right? Anasarca hota hai nephrotic syndrome mein, pot belly hota hai because of ascites. So this is what these babies will look like. So subcutaneous fat is preserved. In fact, because of edema, this will be above the 50th centile. So there's edema. You can see this dermatitis, scaly rash called as flaky paint dermatitis. You will see some depigmentation of hair called as flag sign, which represents, that is time pe usko nutrition nahi mil raha tha. So that's flag sign, lack of nutrition at that point. Fatty liver can happen. lethargic, poor appetite. So these babies are lethargic and they have a poor appetite. Protein deficiency ka sign hai. On the other hand, marasmic babies are who are not getting any calories, no food. So their albumin relatively is preserved, but they don't have subcutaneous fat. Look at them. You can see the bones, right? These facies are called simian facies. So the tricep skin fold is thin, right? There is subcutaneous fat which is wasted, muscle wasting is happening. So this is less than third centile. No edema, in fact, loose skin, there's no fat underneath. Simian facies, and these are very voracious. If you give them food, they'll eat like crazy because they've been deprived of nutrition for a very long time. So that's voracious feeders, right? So this difference, super important, very basic stuff, you can't go wrong here. Then we talk about the management, right? So if you remember in PSM, we had seen WHO growth reference charts. वहाँ पे हमने बोला था green is road to health. If it is yellow, meaning between -2 to -3 standard deviation, what do? You do nutritional counseling. But if it goes below -3 standard deviation, you have to refer to community health center. So now if you refer, what do you do is what we are learning, because that's where the pediatrician is supposed to be, CHC. So what would you do? So first thing is to decide whether they need to be admitted or not. So admission ka criteria hai if they have a poor appetite or they have edema or any medical complications, you will admit. Otherwise, you'll do outpatient management. So for hospital management, there are a few issues that we need to target that you can remember through shielded mnemonic. So let's do this. So shielded. So S stands for sugar, right? So sugar matlab hypoglycemia. So if you remember in neonatal hypoglycemia, we had discussed 40 and 45. Blood was 40, plasma was 45. In every other baby, we take the threshold as 54 mg per dl. So any baby who develops hypoglycemia, again we want to give them IV dextrose. So you want to give them IV dextrose. First it can be a bolus followed by an infusion. Okay, so that's hypoglycemia. They are at a risk of developing hypothermia. So we want to prevent that. They are at a risk of multiple infections. Then they may have electrolyte abnormalities which you want to correct. They may be dehydrated, very important. Now the other signs that we will learn to assess dehydration, right, would be we check their mental status, we check skin pinch, but in these children that may not be reliable, right? Like we saw, skin thickness will vary, their mental status will vary. So that is why the best method to assess dehydration in these children is by assessing the urine output. Okay, so we assess their urine output. And finally, deficiencies. They may have many vitamin and mineral deficiencies that we want to correct. Very, very important, you will correct everything except iron, and that's what they ask. So iron is corrected from the second week onwards, not in the first week, because we know iron tends to increase the chance of sepsis, right? So we don't want to correct iron or supplement iron in the first week when we are treating SAM. Okay, so this is what is shielded. So we treat it in two phases. First week, as we discussed, a stabilization phase, and then you have to rehabilitate over 2 to 6 weeks. So in the stabilization, you start slow. You start with an F75 diet. It's a preformed, nutritious meal which contains 75 kilocalories plus 0.9 gram per 100 ml. So depending on the requirement of the child, you will give this. So we are trying to standardize how much we are giving, right? So remember, not iron. That's the question that they can ask you. Rehabilitation phase, now you increase it. So F100, which is 100 kilocalories, and you are going higher on protein now. So 2.9 gram protein per 100 ml, and you also add iron. This question was asked last year. What is the definition or criteria of primary failure? So first, the baby has not regained appetite by day 4 or not started to lose edema by day 4, or any edema on day 10 is abnormal, or you have not gained 5 gram per kg per day by day 10. Alright, so we assess at 2 time post, day 4 and day 10. So remember this, no appetite regain, not starting to lose edema. Any edema at day 10, 5 gram per kg per day by day 10. Right, so this is about SAM. Now we talk about breastfeeding. So super important. They ask you multiple questions here. All right, so let's start by comparing breast milk from cow's milk. They have asked these numbers also. So here the rule is breast milk is better. If it's not better number wise, we will say quantity nahi, quality better hai. Otherwise, we'll say quantity is better, right? So that's how you always have to make breast milk win, either quality or quantity. So in proteins, you can see the quantity is not winning. So we say nahi, but quality is better. Where we say that our soluble proteins are much higher. Okay, so this is what you need to know. Soluble protein or whey protein is the soluble protein is higher in breast milk versus casein, which is insoluble, is higher. C for C, casein in cow is higher. Taurine and cysteine, so the quality of protein also is better, where we have these sulfur containing amino acids like cysteine, taurine, which help in, brain development. We also have lipid in terms of docosahexaenoic acid, which is your essential fatty acid, which is present in breast milk. So this is what breast milk is meant for humans, right? So that's how it develops more brain than obviously cow's milk. No offense to cows, but yeah. Then you have lactose. So lactose is again more in breast milk. So it's sweeter, it's more palatable. Calcium phosphate, so cow's milk obviously is winning hands down, but then we say that no, the ratio that we have is more soluble. So that's where again we are making breast milk win, saying that the calcium phosphate solubility ratio is more in breast milk. Apart from that, you can see vitamin C definitely is richer in breast milk, and so is vitamin D. All right, so that's what we are comparing with cow's milk. Out of animals, if they compare which has more energy and proteins and everything, buffalo followed by goat followed by cow. Okay, so that has been asked in one of the UPSC exams, right? So just remember. Then let's talk about why breast milk is better in addition to, the nutritious value. It has anti-infective properties like TGF-beta, lactoferrin, IgA, bifidus factor, bile stimulated lipase. So all of these are the things which, prevent various diseases like asthma. You have necrotizing enterocolitis, overall the intellectual ability of people, children who've been breastfed is much better. So hands down, anything they ask, breastfeeding would be protective for that. Then the type of breast milk. So colostrum, is the first feed that the baby gets for the first 72 hours of the baby's life, and this is considered to be the baby's first immunity, because this is what is very rich in immunoglobulins. All right, so this is where this is very good for baby, and that's why we say you should not give any top feed. A lot of practices give water, honey as the first feed, should never be given. Only colostrum should be fed to the baby. Then the breast milk quality, right? After colostrum, it switches into a transitional stage which goes on for the first 2 weeks of life, right? And followed by that, you have mature milk. So see how nature so beautifully, has created customized food for the baby of that particular age. Then in mature milk as well, there are 2 stages. The first feed the baby will get. First, you want to quench baby's thirst, right? So the fore milk is what is richer in water. It is what is richer in protein. It is richer in vitamins and minerals. So you want to remember, a protein shake. If you have a protein shake, a whey powder, what is that richer in? You mix it in water, protein hota hai, vitamins, minerals hote hain, carbohydrates hota hai. So this is what is fore milk essentially. And hind milk is what is rich in calories. So this is what is richer in fat. So the learning point here is that a baby should be fed both. If you get a scenario where a mother says that my child is not gaining weight but is showing adequate signs of feeding, what does that tell you? That tells you that mother is only giving the baby fore milk, right? So that is quenching the baby's thirst and baby is peeing on time, but you are not gaining weight. So that's why you have to counsel this. How would a first time mother know this, or any time mother know this? So you have to counsel the mother that you have to feed completely from one breast and then switch to the other. right? Because hind milk is very, very important for the baby, right? So that's something we have learned here. So what are the signs of adequate feeding? Very, very important. So a baby would usually sleep for 2 to 3 hours after every feeding, right? Should pass urine 6 to 8 times in a day and should be gaining weight. So all three of them are signs that the baby is fed adequately. All right. So this is very, very important. Few questions. Breast milk is deficient in what all nutritions? So vitamin D, even though it's higher than cow's milk, still it's not as much as the baby needs. So that's why we start 400 international unit supplement right at birth for vitamin D. Breast milk is deficient in vitamin K, and that's why, babies may develop hemorrhagic disease of newborn. So that's why we give every baby 1 mg vitamin K intramuscular injection before discharge from the hospital. And it is also deficient in iron, but we don't start iron supplements until 6 months. So usually started from 6 months, but not at birth. So 3 things which breast milk is deficient in. Maximum breast output is at 6 months, right? So that's when the mother will start complementary feeding. So that's 6 months. Then any mother who's pumping breast milk, expressed breast milk can be stored for how long? So at room temperature, it can be stored for up to 6 hours. In a refrigerator for 24 hours, and in deep freezer, it can be stored for as long as 3 to 6 months. Complementary feeding. When you start top feeding at 6 months, it has to follow a fast. It need not be, fancy Cerelac, expensive. No. What they say is it should be acceptable. So depending on that regional location you feed, acceptable hona chahiye, feasible hona chahiye, affordable, sustainable, safe. So that's the criteria for complementary feeding. Very important, these two they ask you. Adequate positioning and attachment for breastfeeding. Positioning less likely to be asked, very basic stuff. So body should be well supported. Occiput, shoulders and buttocks should be in one line. Baby is turned towards the mother and abdomen of the baby and mother should touch. So what is more likely obviously is this, and here also one question only. Which areola should be visible? Upper. So small part of upper areola can be visible, not lower. So that's what they'll make a question from. So remember, vowels stick together. Okay, mouth wide open, lower lip everted and chin is touching the mother's breast. So these are the criteria for adequate attachment. And this was asked last year, really crazy question. So this is from the guidelines, infant and young child feeding guidelines. All right. So this is where in a baby from 6 months to 1 year, how much to give was asked. So half to 1 katori, where each katori is roughly 250 ml. 3 times in a day you are giving that. After 1 year, you give 1.5 katoris 5 times a day, right? So don't know why and how they ask this, but this is what you need to remember. So now let's start discussing the approach to rickets, all right? So here we'll first draw this very, very important table and understand it rather than memorizing it, all right? Because there's no memorizing it. Only if you understand will you be able to apply in the exam, right? So it's pretty simple. Whenever I say vitamin D, all right, the rule is calcium and phosphate both are going to go in the same direction. Means if vitamin D is deficient, both will fall. If it is excess, both will rise. All right. Anytime calcium is low, it will cause the parathyroid to increase. Whenever PTH is high, ALP is high, because ALP is what is repairing the bone. So these are the 2 ground rules you remember. What are the 2 ground rules? Vitamin D mein both calcium phosphate go in the same direction. Low calcium stimulates PTH, right? So this is what I have to understand here. So now let's discuss what happens when you have nutritional rickets, right? Anybody who's not getting adequate vitamin D. Here, the problem is obviously that vitamin D is deficient from the diet itself. So what happens to calcium phosphate? Both of them go down. Low calcium will stimulate PTH, right? So obviously because vitamin D is not there, what will be the 125 dihydroxy vitamin D levels, which we call as calcitriol? They will be decreased, right? Because hey, vitamin D, if I give, it will respond. So response to vitamin D is very good. And that's why the treatment here is simple. You give vitamin D supplementation. You remember in neonates, we were giving 400 international units per day for the first 1 year, right? So here you are giving 2000 international units for 12 weeks. So the therapeutic dose of vitamin D is 2000 for 12 weeks. All right. So there are many regimens, but this is what is used most commonly. All right. So this is for nutritional rickets. Now, we have two conditions which are vitamin D dependent rickets. Okay, both are autosomal recessive. In type 1, the problem is 1 alpha hydroxylase is not there. Remember, similar to CKD, chronic kidney disease, the kidney is what makes this 1 alpha hydroxylase. So that's not there. So in vitamin D deficiency, the defect is that final enzyme is not there, and that's why we don't have the active 125 dihydroxyvitamin D3. Okay, so again, the problem is the same. Ki vitamin D nahi hai, so calcium phosphate will be low and PTH increases. Will there be response to vitamin D? Yes, but which form will I have to give? I'll have to give the active calcitriol, and then I will have response. When we talk about vitamin D dependent rickets type 2, this is where the problem is end organ resistance, that I have vitamin D but the receptor is resistant. So again, the end result is I don't have vitamin D. So calcium phosphate low, PTH high. But what happens to the levels of calcitriol? They are very high, right? Because end organ resistance hai, so the level keeps on increasing. So that's the real difference. Now, how will this respond? So this has a poor prognosis, right? It will not respond. But if I give very supra-normal doses, very high doses of calcitriol, it does respond. Okay, so at very high doses, it shows some response. So that's why these two are called as vitamin D dependent rickets. Okay. Then comes X-linked hypophosphatemic rickets, which is X-linked dominant, and this is also called as vitamin D resistant rickets. And the reason is this is not related to vitamin D. As the name suggests, the problem is hypophosphatemia, and this is